Good afternoon, good morning to those of you coming in from Europe, and a very early morning to those from the US and Argentina. My name is Surinder and I will be your MC for today. Welcome to the 10th Seeing Eye to Eye conference done by the Joint Districts 3300 and 3310. Essentially, these are the Rotary clubs of Peninsular Malaysia, Singapore, and East Malaysia. It is my honor and indeed our team's honor to be with you today. We have had this 9 times physically, this conference. For the first time, we are doing it virtually, obviously because of the pandemic. It's great to be able to do this on the 10th day of the 10th month of a very special, challenging new year. Well, not new, but still a difficult year. We're having this in conjunction with World Sight Day, which was only 2 days ago. And our intention is to continue learning, educating, and motivating each other in all our joint efforts to prevent blindness. We have a very exciting lineup of speakers today. In fact, there are 11 external speakers. They are joining us from all over the world. I will be introducing them one by one. Some housekeeping first, please. Can everybody please go on mute and just let the speakers speak? Also, because time is very short, we have 3 hours and 11 speakers. If each speaker went over by just 2 or 3 minutes, we'd be off by 30 minutes. So to each speaker, I apologize ahead of time that I might need to interrupt you once your time is up. One of us will do that over the system today. Well, as I said, time is of the essence. I would like to actually move straight away to the welcome address. As I said, this is a joint project between District 3300 and District 3310. I would like to now hand over to Chartered President James Gomez, who is the chairman of District 3310 Committee on Blindness Prevention, to have the welcome address from our partner district. Mr. Gomez will be zooming in from Singapore. Over to you, Chartered President.
I'm still muted. Okay, thank you. It's nice to be given the honor to start this day's proceedings. A very good afternoon to our guests of honor, District Governor 3300 Teo Kwan Sri and District Governor 3310 Raja Mohan Munasamy, eminent speakers, fellow Rotarians, and friends from far and near, gathered in this platform for the annual 10th International District Seeing Eye to Eye Conference. I distinctly recollect in 2012, when my good friend and buddy, PhD Datuk Kulasekharan Sabaratnam, floated the idea of the need for such a conference of this nature. We were at the executive launch of Marina Mandarin Singapore then. I could feel his passion and his strong desire for initiating such a conference. After a short discussion on the objects of this conference, both of us could see eye to eye on the need for such a conference in our districts. District 33 given the unenviable task to kickstart this conference in Singapore in 2012. We had the full support and blessing Governor then, Dr. Haji Zaini Abdul Kusa. He has all along been an ardent supporter of this conference, and I'm sure he is with us this afternoon. As far as I can collect, this is I'm indeed very happy to be associated with this annual conference, as I've witnessed the conference growing from a small initiative to what it is today. It has grown by leaps and bounds. I must congratulate the organizing chairman of this year's conference, PDG Siti Zubaida, and her team for having brought together such an array of eminent personalities in the eye industry to share their knowledge and expertise in the field of blindness prevention. I'm sure that the sharing by our eminent speakers this afternoon will certainly motivate everyone in the industry to put in greater effort for a long-term objective of totally eradicating the scourge of blindness from this world. The rippling effect of your sharing, we hope, will be the emergence of new Rotary clubs coming forward to do their part in blindness prevention. Together, we can achieve more and reach our target faster. So, my dear Rotarians, do include blindness prevention program in your annual club calendar from henceforth. Have an enjoyable and enriching afternoon and big piece of this year's event. Thank you.
Thank you, Chartered President James. We have now a video that we would like to share to you. So over to the video, guys.
My name is Paramita Kwa. I work in Nepal at Seva office as a program manager. My hope for Sight Beyond 2020 is good quality eye care services throughout Nepal. Thank you.
My name is Vivian Yin. I work in Canada as an ophthalmologist and oculoplastic surgeon. My hope for Sight Beyond 2020 is that everyone has the equal right to sight. COVID-19 has shaken the stability of our world beyond our imagination. But can you imagine how hard it must be and how frightening it must be to deal with this while not being able to see? Now more than ever, we need your help.
My name is Paul Courtwright, and I'm the chair of the board of the Kilimanjaro Center for Community Ophthalmology. My hope is that all populations, those truly at the end of the road, the most disenfranchised, have access to good quality eye care in the coming years.
Hi, I'm Laura. I live in Canada and I'm on the Seva Canada board. And my hope for Sight Beyond 2020 is access for all women and girls.
My name is Andreas. I'm working Seva as a program director of Nepal. My hope beyond 2020 is to provide sight more to the people who are residing in the human part of the country. Thank you.
I'm Dr. Martin Spencer, and I work in Canada as an ophthalmologist and as a board member and volunteer for Seva Canada. My hope for Sight in 2020 is for Seva to reach the unreached, particularly women and children.
We are Seva Cambodia team. We work for Seva Cambodia Sight program. Our hope for Sight Beyond 2020 is to make everyone have access to eye care services in our community.
My name is Ferris and I work in Canada as a Seva Canada board member. My hope for Sight Beyond 2020 is for people everywhere, including all girls and women, to have their eyesight restored so they can dream and succeed.
Hello, I'm Dr. Ken Bassett, the Program Director for Seva Canada. Eye programs in almost every country now have comprehensive community outreach strategies, sufficient number of eye care professionals, and an array of training programs for all levels of clinical and administrative personnel. With this infrastructure in place, treatable blindness will soon be a thing of the past.
My name is Penny Lyons, and I'm the Executive Director of Seva Canada. COVID-19 has shown us that we are all connected and that we are all vulnerable, some more so than others. I hope that this realization will galvanize development organizations, governments, and individuals to focus on creating strong health systems for primary health care. This is the first step in eliminating preventable and treatable illnesses, including blindness. Everyone, no matter where they live or what their circumstances, has the right to sight.
My name is Fortunate, and I work in Tanzania at the Kilimanjaro Center for Community Ophthalmology as a project coordinator. My hope for Sight Beyond 2020 is for everyone to access quality eye care, disregarding of their gender, financial status, and geographical location.
That was a video from Seva Canada, one of the NGOs, Canada-based, but with an outreach program across the world. And it's just one example of the NGOs that Rotary clubs are working with. We look forward to hearing more from each and all of your countries as well about this fantastic program. Today, we are blessed with both district governors being present. I would like now to hand over to the District Governor of District 3310. This is Governor Raja Mohan to give us his address from Singapore. Over to you, Governor.
Thank you, MC Surinder. Organizing Chair, PDGCT, Governor K.S. Teo, fellow Rotarians, Rotractors, and honored guests. Good afternoon and warm greetings to all from near and far. Several clubs in District 3310 have adopted blindness prevention as their signature projects, which includes 2 global grant projects, 7 projects in the district, and 4 outside the district. Let me quickly share the projects. The 2 global grants projects will be carried out by E-Club of 3310. They are Gift of Sight in Bandung for 1,000 cataract surgeries, a Gift of Sight with the RC Dhaka Royal in Bangladesh for 500 cataract eye surgeries. In Sarawak, E-Club 3310 has one other joint project with RC Sarike to do 200 cataract surgeries for their community in Sarike. This is planned in January 2021. In Johor, RC Tanjung Pagar distributed free spectacles to needy school children in Tangkak, Ledang. In Singapore, RC Singapore Heartlands, where our District Prevention of Blindness Committee Chair, CP James, come from, conducted a total of 6 eye screening clinics on selected Sundays, screening about 750 individuals. RC Pasir Gudang have a permanent eye center which is open to all to the public Mondays to Friday for free eye screening. If anyone is detected with a cataract problem and if they come from a needy background, then they will be referred to the authorities for financial assistance, and the operation will be conducted at the hospital. In Sarawak, RC Kuching Central and the Ophthalmology Department of Kuching General Hospital have their annual program for cataract surgery planned for the year. Sarawak has been the forerunner in the cataract surgery. On an average, they conduct about 300 cataract surgeries a year, and this is done in collaboration with the local hospitals. These activities are carried out in remote areas through the mobile buses fitted with eye surgery facilities. Finally, in Johor, RC Batu Pahat have just set up an eye care center. So clubs in 3310 will continue to work with hospitals, corporations, other VWOs, and like-minded people in the community to create awareness and provide eye care in support of avoidable blindness prevention. Thank you. Back to you, Surinder.
Thank you, Governor. It is really good to hear how much your district has been doing in Johor, in Singapore. You mentioned Sarawak and Sabah a lot, but you also mentioned the other neighboring countries in ASEAN that your district clubs have gone out into. That's very inspirational to hear, and I hope you keep doing this even more, especially now with COVID and with access to eye care being so important. We now have our own district governor here in District 3300. I would like to hand over to Governor Teo Kwan Swee, who is dialing in from Kuala Lumpur. Over to you, DG. You are on mute, sir.
Okay, right? Can you hear me?
Yes, we can.
Okay. Organizing Chair, past District Governor Siti Spider, Governor of District 3310, Raja Mohan, past Assistant Governor Datuk Kula, Chairman of District 3300's Action Group on Blindness Prevention, Charter President James, Chairman of District 3310's Committee on Blindness Prevention, eminent speakers, my dear friends and fellow Rotarians. It is so heartwarming to see so many of you on board today. It shows we really care and are concerned over the far-reaching implications of blindness and visual impairment for the society, especially considering the marked increase in such cases in young and elderly population in our country in recent years. It is a fact that 80% of the visual disability is avoidable, and it is therefore a great challenge to each and every one of us to make the available knowledge and skills accessible to those communities in greatest need. Now, in alignment with the global initiative for the elimination of avoidable blindness, Vision 2020, the right to sight, many of the clubs in our district have embarked on similar projects, but with different names, which have eventually led to the formation of the Blindness Prevention Action Group in our district. The initiatives undertaken by the Action Group are, very briefly, early intervention. Here we carry out vision screening for preschool and school children based on the National Coordinated Action Plan. Spectacles Bank, where we carry out eye screening project and provision of free spectacles for needy students and adults. Diabetic eye care aim to create awareness on detecting and treating diabetic eye disease early to preserve sight. Adoption of elderly home, where we reach out to the elderly in need to provide them a better quality of life with free eye screening and provision of cataract surgeries. Industrial eye safety. Here we promote eye health and safety awareness. As I think all of us know, 90% of all industrial eye injuries are preventable with wearing of proper eye protection gear. I must put on record my heartiest appreciation and gratitude to the district action groups on blindness prevention, which has done tremendous amount of commendable job in this area over the past many years. Thank you. I hope you have an enjoyable evening. Thank you.
Thank you, Governor, for officially declaring open our conference today. We would now like to share a launch video with you for this conference. Over to the video, guys.
Surinder, you're on mute.
Sorry about that, I was on mute. Apologies. I'd like now to recognize all the various people from around the world who are dialed in. You can see their flags here today, but let me very briefly say, from the Americas, we've got Argentina. From Europe, we've got UK, France, and Netherlands with us today. From Africa, we've got Uganda and Nigeria. From Asia, we've got our largest delegation, including Pakistan, Nepal, India, Thailand, Singapore, Malaysia, Indonesia, Bangladesh, Philippines, Brunei, Cambodia, and Laos. And we've also got Australia. So all in, we're talking about 20 countries, which is very appropriate for our theme this year, which is ASEAN and beyond. So with that, I would like now to actually talk about our first speaker. We are going to now go into the first session, which is about children's vision care and eye care in elderly. Our first speaker is Dr. Andreas Mueller, PhD, who has worked as a consultant with the World Health Organization's Vision Program. That's him that you see on the screen now. He has worked in various sectors. He has covered public health via academia, via an NGO, and also within the UN system. So we hope to learn from his experience covering so many different areas. Between 2011 and 2016, he actually led the World Health Organization's Prevention of Blindness program at their regional office for the Western Pacific region. He was responsible for the development of the first WHO regional action plan for preventing blindness. Particular research interests are of relevance to us because he likes to focus in eye care services for low and middle income countries. And this is very relevant, especially for our part of the world, including how to use technology for population screening for eye diseases. So we are very excited to have you, sir. Over to you, Dr. Andreas Mueller.
Good afternoon and good morning, good evening, wherever you might be around the world. Thank you very much for inviting me to this very important meeting. And before I start my presentation, I would also show my gratitude and say thank you for all the fantastic work that your Rotarians are doing around the world in the space of eye care. Thank you so much. I will now share my screen. I hope it works. Okay. So I will be talking a little bit about the high-level work on the prevention of blindness globally and current activities at World Health Organization. You might be aware, you probably will be aware, that last year in October, WHO launched the first ever World Report on Vision. This is a very important document for the sector that outlines the current scope of the problem around the world and also makes very specific recommendations in terms of strategies on how to overcome the burden we're facing globally. More recently, in May this year, the World Health Assembly resolution on integrated people-centered eye care, including preventable vision impairment and blindness, was adopted, which in fact endorses the World Report on Vision and gives effect to its recommendations at the highest level possible. So we're certainly very encouraged and excited about that, giving the work that we're doing the mandate of all the member states of WHO, supporting eye care as a priority.
Dr. Mueller, we cannot see your screen. Are you sharing your screen? Because we only see your image.
Ah, okay. I was sharing. I'll try again. Let me try again. Is that coming now?
Yes. Can you please put it into full screen mode? Thank you.
Yep, will do. Is that okay?
It's still small. Full screen, please. Slideshow.
Yeah. Should be slideshows.
You can click on the from beginning icon. Yeah.
Okay. This is better. Thank you.
It's okay now?
Yes, it is.
Okay. So there you see a picture of the World Report on Vision that I just mentioned. And I've also mentioned the World Health Assembly resolution adopted in May this year. So I will give you a very brief overview on the World Report on Vision in case you have not come across that. So what does the World Report on Vision say? It gives us some new numbers on the scope of people with vision impairment in the world. And these numbers do differ from previous reports. The World Report on Vision says that at least 2.2 billion people around the world have a vision impairment. And because of population aging, because of growing populations, changes in lifestyles and NCDs, non-communicable diseases, the eye conditions are projected to increase in numbers. However, of those 2.2 billion, at least 1 billion people have vision impairment that could have been prevented or is still to be addressed. And the main conditions that are responsible for vision that can be prevented or addressed are unaddressed refractive or uncorrected refractive error, so myopia and presbyopia, 124 million. And the other main group is unaddressed presbyopia, people that lack near vision correction, which is over 800 million people. And we still, unfortunately, see cataract with over 65 million people around the world as a main cause here of people with avoidable or treatable vision impairment. But if you look at these figures, it shows that just with spectacles alone or with cataract surgery, we could address by far the largest chunk of all the people that are still unnecessarily suffering from vision impairment in the world. So the Vision Report, the World Report on Vision also talks about barriers, barriers to accessing eye care services. It talks about the disbalance comparing rural and urban areas, where people in rural areas, most commonly around the world, even in high-income countries, less so have access to the eye care services they need. The report addresses affordability, accessibility, and availability of services to all the people they need, and shows some substantial gaps there in the service delivery. It also shows that there's an uneven distribution across countries that are low or middle income, or regions low and middle income compared to high income regions. And that difference is quite substantial in that unaddressed distance vision impairment in low and middle income regions on average is 4 times higher than in high income regions. Within countries or within regions, some of the high risk groups include people that live rurally, low income, women, elderly people, indigenous people, minorities, ethnic minorities, and people with disabilities. So we certainly still have a big job ahead of us to overcome these levels of inequity, not only across countries, but also within countries. So how can this be that in the year 2020, we still have such inequities in delivering eye care services, where at the same time, we have such highly successful and highly effective strategies such as spectacle correction or cataract surgery at our hands? How can it be that we still have 2.2 billion people around the world that have vision impairment? So the World Report specifically outlines the lack of integration of eye care into health systems in so many parts of the world, not only low and middle income countries. It highlights the fact that very often eye care services, which are specialized services, but still are often only available at specialized facilities, at tertiary hospitals in cities, and are not properly or not enough integrated into the healthcare system at a broader level. So the World Report actually recommends or makes 5 very specific recommendations to overcome the inequities. So the key recommendation of the report is to make eye care an integral part of universal health coverage. So UHC, universal health coverage, you probably are aware, is like the overarching global framework that countries adhere to, and certainly WHO adheres to, and it aims that all people and communities can use the health service they need. The services are of sufficient quality to be effective, while they're ensuring the use of these services does not expose the user of financial hardship. And the strategic framework to achieve this level of integration, UHC, is what the report calls integrated people-centered eye care. So it makes a recommendation, very specific, and we'll talk about this in a minute, around the concept of integrated people-centered eye care in health systems in order to support eye care into universal health coverage. It also recommends for countries to carry out high quality research in the area of eye care, to collect data periodically within the country, to be able to monitor trends and evaluate progress, very importantly. And it also specifically highlights the need to increase awareness amongst people, amongst communities, and engage people and empower people in regards to eye care, to look after themselves and to take action. I will briefly talk to you about this concept of integrated people-centered eye care, because that concept certainly shapes the work we do at WHO at present. So what does that mean? IPEC means that eye care services are managed and delivered so that people receive a continuum of eye care interventions, going all the way from promotion, prevention, treatment, and rehabilitation. So in the past, historically, often eye care and interventions has focused on treatment only, but this concept is looking at the wider picture in that space. IPEC also is addressing the full spectrum of eye conditions according to people's needs. So it's not only about blindness or vision impairment, it's eye conditions that reduce the quality of life of a person, that impacts on what the person can do for a living, etc. So it's not only talking about blindness anymore or vision impairment. The concept also highlights the need to coordinate services across the different levels of healthcare and sites of care within and beyond the health sector. And it recognizes that the importance to engage people as participants and beneficiaries of eye care services throughout their lives. So I'll briefly outline the 4 key strategies on how the report says we can achieve integrated people-centered eye care. The first one, again, is about empowering and engaging people and communities. So there is certainly a need to raise awareness about the importance of early identification of eye conditions, the need to prevent and address vision impairment, and to empower communities. The second strategy is about the need to strengthen primary eye care. Most countries that I go to and work in, whether it's in the Western Pacific region or in Africa, in the capitals, you have wonderful tertiary eye hospitals. But as soon as you come to the district level, or certainly the primary level, services are very rare and not evenly distributed. So there's a specific recommendation here to reorientate the model of care towards stronger primary eye care services, knowing that most eye conditions can actually be addressed at the primary level. There need to be guidelines and policies developed on what that care should look like, and they need to be working closer with healthcare workers and nurses so they can contribute based on their competence rather than what their job titles are. And the need for outreach support. And I know Rotary is already working very hard in that space. The third strategy, and I mentioned that previously, is the need to coordinate services better for the individual so that there are effective referral systems from the primary level to the secondary or tertiary, depending on what the need is. These referral systems need to be strengthened, but also for the eye care service within the government system and within the health system Too many times eye care specialists and services are working in towers and silos, and there's not enough linkages between relevant programs such as diabetes program, maternal child health program, aging programs, or other sectors, even non-health related, finance, education, the private sector, etc. So that, eye care talks to the education sector about the importance of school screening, to health promotion programs about the importance of myopia prevention messages and activities, or the aging programs about the specific needs for eye care to the elderly population. And the last recommendation of that particular IPE strategy is about, it's a bit of an odd title, but it's called Creating an Enabling Environment, to make sure that eye care is formally integrated into government frameworks and policies of health, that eye care is integrated into the National Health Strategic Plan. Every country has such a plan. So we have to make sure that we are considerate when it comes to human resource planning, when it comes to budgeting, when it comes to strengthening primary healthcare services. So there needs to be more evidence about the need, the met need of eye care, but also the unmet need for eye care services. There is a need to advocate further for uncorrected refractive error or optical and refractive services to be integrated into health systems. In many countries, if not most countries, these services are only available in the private sector, and cost and quality are often barriers as a result of that in countries. So we in the report certainly advocates for these kind of services to be available within government health systems. I mentioned workforce planning needs to include eye care workforce planning, and there certainly is a need for health information systems or periodic data collection to also collect data on the services and the quality of services for eye care. So these are just some of the tools and packages that WHO is currently developing to support countries in reaching these targets, and so just I won't be going into details, but we, for instance, are working on what's called a package for eye care interventions to allow countries better planning, to identify using evidence-based guidance on what eye care services should be available at each level of the health system, what should be the qualifications of the people providing these services, etc. There are now 2 indicators that relate to eye care, part or will be part of universal health coverage monitoring of countries around the world. And that is a particularly exciting development. So ECRE stands for effective coverage of refractive errors. Basically, how many people that have a refractive error are having access or wearing spectacles or contact lenses. Yeah? And the other one is ECSC, standing for effective cataract surgical coverage. How many people that need cataract surgery actually have had the surgery? So these 2 indicators are being currently considered to be included as formal indicators to measure universal health coverage, and countries all around the world, member states of WHO, will be asked to report against these 2 very important indicators for eye care. So it's a very exciting step forward in the right direction to make sure that eye care is recognized and reflected at the highest level possible. And the last example of our work in WHO is an mHealth or mobile health tool for myopia prevention that we're rolling out with partners as part of an existing health promotion campaign called Be Healthy, Be Mobile, because we know that myopia is increasing fast in prevalence, and its impact, particularly in our part of the world here in Asia, in the Western Pacific region. So this was it from me. Again, thank you so much for the invitation, and I wish you a successful rest of the Congress. Thank you.
Thank you, Dr. Andreas Mueller, who was coming in to us from Melbourne in Australia. Also, Doctor, thank you for keeping to the time. We have to keep to 15 minutes each, and you covered the WHO's plans, their report, the 4 IPAC strategies, and that's a useful start to the conference. Now, just now, earlier today, we had heard from the Singapore, or rather District 3310's Action Group on Blindness Prevention, which was CP James. Now, coming straight from the airport, we have District 3300's Dato S. Kulasegaran, who was indeed the founder of our Blindness Action Group. Dato is just coming straight from the airport, as I had said. Over to you, Dato, for your opening address, please.
I'm very honored to have been asked to say some opening remarks to launch this worthwhile Zoom conference on blindness prevention. To begin with, I would like to express my gratitude to PDG City Zubaida for taking over the chair of this conference, and also to a very hardworking team, among whom none other than PhD Kama, her husband, and then PhD Bo, who else has the city? Number one. Who? Pushpam, and there are several others who whose passion is blindness prevention. Ladies and gentlemen, I am honored to be asked to say a few words at the launch of this conference. Let me put it this way. When we are reminded that every 4 seconds, somebody in this world is 5 seconds, somebody in the world is going blind. And every minute it's it's a shocking statistic. So that by the time I finish speaking, I'm sure that you'll be able to count that at the rate of 12 persons going blind every minute, if I were to speak for 2-3 minutes, right, okay, you'll have about 30 persons or 40 persons having gone blind, needlessly. So, anyway, let me say this. Bearing in mind these awful statistics, we are constrained to do what we can to prevent blind. That's why we started this reaction group on blindness prevention. Let me also say this, that as Rotarians, we have a duty to bring alleviation wherever we see suffer. For us, blindness prevention is not merely something we are passionate about, it's something that needs to be done to make the world a better place for all of us to live. In this context, I must also thank my counterpart, Singapore, CP James Gomez, chairman of the District 3310 Blindness Prevention Committee. Thanks, James, for your steadfast belief in blindness prevention. And ladies and gentlemen, doctors, lawyers, optometrists, teachers, and all of us are joined in this battle against blindness. In this context, I would also like to place a record appreciation to the Rotary Club of Kuala Lumpur, Diraj, and the Rotary Club of Singapore for each having donated 5,000 each, making a total of 10,000 towards the cost of this seminar. You might imagine that holding a Zoom conference would be less expensive and indeed not incur any cost. I think that's a bit of a fallacy because there are costs involved in one way or another. I'm sure the city will be able to attest to that. Having said that, I wish also to place on record my appreciation to all of you, speakers, particularly my friends in London. Dr. Peter Ashall is probably listening and also in Amsterdam, not Amsterdam, in Rotterdam Eye Hospital. Micah, representing the World Eye Hospitals. Singapore, Charity Y, CEO of SNAC, Singapore National Center, and over here, none other than Mr.
Miss Fazilawati.
Yeah, Dr. Fazilawati, the representing the Ministry of. Each of them, our gratitude. Too many for me to mention by name. Let me say this: without the speakers, there will be no conference. Likewise, without the audience, there will be no. All of us are joined in one common objective of preventing blindness, which is why speakers and listeners are jointly committed to this cause. I also wish to thank my district governor, Chokon Sri, and also Mohan. Hi Mohan, the Singapore governor, who is a good friend, for their support. Hi Mohan. And without those support, there'll be no conference. So all of you are important. Surrender Deep and City and Pohu, who are here with me, the Rotary Center as I speak, and also all the others out there who are listening online. I'm told that this is going live on stream, Pohu, to the world, globally. I got friends in US who are listening in to this conference. So I should start by saying good morning, good afternoon, good evening, and even good night to straddle the globe, right? And this is how we must carry message. Rotary is in the forefront, battle against blindness. Let me end by saying that we are all committed to doing battle against blindness as much as we can. And I want to thank each and every one of you, starting with City, our great fighter, champion against blindness, and each and every one of you, my DAGP members and members of the organizing, putting up this very worthwhile effort. Thank you very much.
Thank you very much, Dato' Kula, for your opening address there, and also for continuing to motivate us together with CP Gomez in the respective districts. It is time now to move to our next speaker, and this is a project about cataract. Let me get that right. The Himalayan Cataract Project. I'd like to introduce Dr. Sanduk Ruit. Dr. Ruit has had a very distinguished career with early education in India, Nepal, Netherlands, and then Australia. Indeed, he is joining us today from his home in Nepal, where he's currently the executive director of the Tilganga Institute of Ophthalmology in Kathmandu. He is also the professor, National Academy of Medical Sciences, also in Kathmandu. Since in 1994, Dr. Ruit has been co-director of the Himalayan Cataract Project. As I said, he has had a very distinguished career, but I would like to cover a few things a few awards and honors. He's obtained the National Order of Merit Gold by His Majesty the King of Bhutan in 2015. The next year, he was awarded the Asian Game Changer Award, 2016. In 2018, he received the Padma Shri from the Government of India. This is among the highest civilian awards that are available in India. It's awarded annually on Republic Day. And just last year, Doctor received the Prime Minister's National Talent Award. So we are very honored to have such a distinguished doctor, a distinguished gentleman with us. Doctor would like to start, in fact, by sharing a video about his Himalayan project. So over to you, Dr. Sanduk Ruit.
Thank you very much, and thanks for asking me to come and speak to such a distinguished audience. And I'd like to start on by a case a video, a case report of a cataract patient who is bilaterally blind. Do you have the video there? Yeah. Can you see the video?
Yes, we can.
Yeah, this is a lady who is about 30 years old with almost total cataract in both eyes. And she is undergoing cataract surgery, which we call small incision cataract surgery. And the next day, patches are removed, and she's a different person just the next day. And unfortunately, she's also got a small baby who was born when she was blind. So she's never seen the baby before. And this child is extremely malnourished. And if she was kept blind, I would probably feel that the child would have faced a very bad outcome. But I think after she regained her vision, which is, cataract is such a cost-effective, and we have now 6 years later. 6 years later, if you look, the lady, tries to move around in the family with much stronger authority, and the child has grown up to become a boy who is going to school now. I wanted to share this video because you need to see the whole cycle of being blind and how we can make them see, and how that impacts into the near and the dear ones in the society of a person who really is probably living in one of the remotest part of the world. We have now been able to simplify and make the surgical procedure available for a large volume of people at such a small cost, and actually predict the outcome. And the outcomes are so good and can be done in large communities with extremely high quality. And not only these could be done in high qualities, but this could also act as a cost recovery for the institute. Yeah. See, the boy now is starting to go to school, and partly because the lady could see, the boy must have survived the malnutrition, and now is going to live a long life later on. Yeah, go back to slides. Yeah. So I will be talking to you some of the experiences that we had in the last 25 years of our eye care in Nepal and elsewhere. And if you look at the global facts about blindness, you see that about 217 million people are suffering from moderately severe visual impairment. And of that, about 36 million people are blind. And 4 out of 5 need not be blind. They're avoidable. 89% of these visually impaired people live in low and middle income countries. Cataract continues to be the most important cause of blindness and most important cause of avoidable, curable blindness. And when we started 25 years ago, the cataract treatment scenario was not like today. It was pretty primitive, and we started with a mission to provide sufficient in terms of numbers, successful in terms of quality, and sustainable in terms of financial sustainability, modern cataract surgery in the community. And when we started in the beginning, we found some of the barriers that we studied. One important barrier at that time, 25, 30 years ago, was the cost of high quality intraocular lenses. These lenses used to cost about $200 and were not easily available. So getting modern cataract surgery to the common people in this part of the world was a very, very big luxury, and it was not sustainable. The second was adaptation of good quality surgical technique and make it appropriate and simple without losing the essence of quality. And of course, the cost and complexity of the equipment. So we started doing a lot of research, especially in Nepal, in the early days, late 80s and early 90s. And in 1990-91, we published the first results of the extra cap with intraocular lens implantation long-term in a developing country. This was probably one of the first reports done in a developing country. And that actually aroused a lot of controversy because a lot of people in the West believed that intraocular lens implantation, modern cataract surgery, may be too complex, too expensive in this part of the world. But we pushed on. And it took us nearly 5 years to work very hard, simplify, adapt, and test, and produce very, very good standard operating manuals. And then finally, through the platform of the Fred Hollows Foundation and the Himalayan Cataract Project, we started disseminating it globally. And it became extremely popular in Asia and Africa and South America even. And from the conventional extra cap IOL, we modified the small incision surgery, which was in the beginning called as a mini nucleus extraction by the Israeli surgeon Blumenthal, and used to do it as an office procedure. Well, we brought that out and used it more in a high volume community level, modified the whole surgical delivery system. And of course, this is simple, low cost, and great outcome. And there were a lot of criticisms at that time whether this is too risky, and the results are not good, and it's cheap. So finally, we landed up doing a randomized clinical trial in Nepal, and I went on to do the small incision cataract surgery, and we had the famous Dr. David Chang, who is one of the well-known persons in phacoemulsification, did the phacoemulsification surgery. And we did a randomized clinical trial and studied the patients for the next 1 year. And, absolutely sustained results. And the visual outcome, uncorrected and corrected, both were extremely comparable in the process of the post-op. The only, difference was the phacoemulsification was about 20 times more expensive in terms of consumables and capital cost. And so after streamlining this surgery, it started to get very, very popular. And because of the clinical trial, this surgery was much easily adopted by many countries in the world. And I'm pretty sure that this has indirectly helped in raising the cataract surgical rate in many parts of the world. And in Nepal, we have had about 49 countries, people come and train this surgery in the last 20 years. And we took it to Vietnam, China, Thailand. In Thailand, now it's interesting, they have a very strong phacoemulsification, very high quality surgery. But for the community programs, the small incision cataract surgery has become very, very popular. And they are using it, that increases the reach and the quality of the poor people who otherwise won't be able to have this kind of surgery. In North Korea, we continue to improve the quality of surgery in North Korea and quality of the training of the doctors. Indonesia, we have been working for the last 10 years almost, yeah. And the important thing is training the doctors, training the team, and making them aware that a setup like this with the proper, care of quality assurance and standard operating procedure, we can have fantastic results. Nepal, this is my partner, Dr. Jeff Tebin. We work together at the Himalayan Cataract Project, taking it around the world. And Myanmar, in some parts of India. many parts of Africa. And I would still believe that to some extent, small incision, good quality temporal section, small incision cataract surgery still has future for many years, for at least 5 to 10 years. The results are very good. Training is a little difficult, but it's cost effective. And this is a pictorial, steps of the small incision cataract surgery. The phacoemulsification, we do it quite in large numbers. And this is the surgery of choice now. Extremely good result. Cost is still, but training is not very easy, but still, it's part of the curriculum, and equipments are not so simple. But again, this is the choice of surgery for an upcoming choice of surgery for cataract. And with the Himalayan Cataract Project and Tilganga Institute of Ophthalmology, now we are transferring the model of eye care to other parts of the world. For example, in Myanmar, Indonesia, Bhutan, Cambodia, Ghana, Ethiopia, Cameroon, Nigeria, and many other parts of the world. And I have always, believed in empowering the local people. Unless and until you empower the local people, no program is going to run properly. And you have to, allow to develop ownership. So the essence is a good governance. You need to have a business plan. You need to build a very good team. And there has to be a quality assurance and audit. And sustainability is extremely important. And especially with the advent of, with the COVID now coming, outreach programs are going to be limited. And we continue to, the prevention of blindness program especially continues to look at models which can be effective, which can work. And I believe in a model like a community eye hospital, which I'm going to describe to you, is going to be very appropriate for many parts of the world. And this is a achievable, autonomous, sustainable model where we look at quality at the community. It's a scalable model, 3 to 4 floors of the building, and the total cost of land, infrastructure, equipment, first 3 years of running is about $2.5 to $3 million. And it gives very high quality cataract surgery, both phaco and small incision cataract surgery. And we conduct extremely smart refractive error programs. I emphasize smart refractive error, including optical dispensing. This has to be a very good program for refractive error. And of course, medical retina, glaucoma, especially for diabetic retinopathy, periodical subspecialty facility, training programs, community screening. This is for our population catchment area of 1 million population, for about 1 million. A community eye hospital. And again, it's important to have a business plan, quality assurance, team building. And it's very important if you work in other parts of the world. The most important thing is, allowing the development of ownership for the local people. And of course, a little bit of passion always is very good. And a fantastic leadership, so important. And they need to have a strategic management plan. We have a center in Xining in China, the community, and one in Hetaura is really a good model where it is serving at a very poor area, but still able to deliver high quality and meet its own operating costs and be sustainable. And they, 2 doctors does surgery of about 4,000 to 5,000 every year. Kalimpong in northern India, a small facility, but continues to deliver very high quality eye care for the whole region. And now we have recently, established one in Bhutan, in Thimphu. And we're going to establish one in Ethiopia soon as the COVID phase goes up. And now in Tilganga, we have a surgery center where we see patients, and both Tilganga and its subsidiaries, we see about 2,000 patients a day. The Fred Hollows intraocular lens lab, and the Nepal Eye Bank, training and education, a very busy program, research, community outreach programs. And the operating facility, there are about 10 operating theaters. I want to mention a little bit about the intraocular lens manufacture. You know, way back when we started with modern cataract surgery, one of the barriers was the availability of low-cost, high-quality intraocular lenses. And when we thought about manufacturing intraocular lenses in Nepal, people thought it's a crazy idea. But it took us nearly 2 to 3 years to juggle and fight, and finally we were able to manufacture the intraocular lenses along with the Fred Hollows Foundation Australia. The cost of the single-piece intraocular lenses came down to less than $4. And this is, I would say, it's a landmark contribution because it allowed large target population to come within the framework of treatment now. And of course, it's we had to continue with the dynamics of the newer products like foldable lenses. We have until now distributed 6 million lenses to 80 countries. And I would say that these are people who would not have afforded the lenses from the multinational companies. And they're extremely, extremely quality assured for CE mark and SGS count. The other thing that we have is very effective eye banking. And I just wanted to show a glimpse of this because we have done quite a few things which are out of the box. And for example, having a cornea excision room right at the crematorium. And this is the only place in the world which has a facility like this. I believe it acts as a advocacy promotion for people who are dying to keep corneas and then and there. And this has been very effective for getting the corneas. And if you look at the number of corneas since we established in 1994, we started with just 2 corneas, and now we can retrieve a little more than 1,100 corneas per year. And we are pretty, sort of self-sufficient on cornea, but we do send corneas to other countries now. The other thing that we do in the eye bank a little differently is to have an annual condolence meeting whereby we put a plaque and the names of the people who have donated corneas, and the people who are grieving will come and they sit in front of the names of their loved ones and lit a lamp and some of them cry, some put flowers, but it's a very moving public awareness movement. And the eye banking public awareness has been fantastic. This is the cataract surgery rate of Nepal, and we started when we were established. The cataract surgical rate was less than 500. Now the cataract surgical rate is very close to 5,000 surgeries per year per million population, and maintaining the quality. Yeah. So thank you very much for allowing me to speak, and I just want to say again, lots of love and empathy, and please try to stay safe. Hopefully we can come across and get across this this situation. Thank you very much.
Thank you, Dr. Ruit, for that presentation. I had thought that this was going to be about the Himalayan cataract in that area only, but it was inspiring to see how much you have reached with your Tilganga organization. Your example of bringing the cost down from $100 to $4 is a massive game changer in this area per lens. Huh? So fantastic work. Thank you so much for sharing that with us. We will move now to the next speaker, who is a local here in Malaysia. I'd like to introduce Dr. Fazilawati. She is currently the head of Department Ophthalmology, consultant ophthalmologist, and pediatric ophthalmologist from Hospital Tengku Ampuan Rahmah. She started her early education here in Malaysia and then moved over to Toronto, Canada in the Hospital for Sick Children. Upon returning to Malaysia, she was posted in Hospital Selayang, which is a famous hospital here in Malaysia, where she continued both her practice and her clinical research, focusing mainly on strabismus, glaucoma, external disease disorders in children, ocular trauma, pediatric cataract, and retinopathy. After 8 years in Hospital Selayang, she then went on to her current position in Hospital Tengku Ampuan in Klang. Besides her academic background, she's also very active in the American Academy of Pediatric Ophthalmology and Strabismus, in the World Society of Pediatric Ophthalmology and Strabismus, which is based in Europe, and also a member of the International Pediatric Ophthalmology. So very clearly, Dr. Fazilawati has got a very strong both academic, medical, as well as a focus on children, which makes her a perfect speaker for our topic, child blindness and early intervention for school and preschool children. So over to you, Dr. Fazilawati. I think you're on mute, doctor.
Okay.
Yes, we can hear you now.
Okay. Can you see my screen?
No, we can only see your image. We cannot see your screen.
So how do I go about it?
Raj, can you please help doctor?
Yeah, sorry. Please click on the share screen icon, the green icon at the bottom of the Zoom screen. And then you will see a few window options. So click on the PowerPoint window and click share.
Yeah, can you?
Still can't see. Yes,
okay.
Yes, it's coming up.
Okay.
Yeah, but you got to switch to your PowerPoint.
Yes.
Yes.
Now you can see?
Yes, we can.
All right, okay. Firstly, I'd like to thank the organizing committee, especially Puan Siti, who is the license officer, contacting me regarding inviting me to talk in this virtual platform. But it's also a learning platform for me as well. Good afternoon from Malaysia. Yeah. I'm going to talk on child blindness and early intervention for school and preschool children, what we do in the Ministry of Health, Malaysia. The outline of my talk will be mainly on childhood blindness, the prevalence and causes, retinopathy of prematurity, which is the leading cause of blindness in Malaysia actually, and how do we intervene to prevent retinopathy of prematurity or treat it, and the programs that we are doing in Ministry of Health Malaysia for preschool children and also school children. Now, it is estimated that the number of blind children is about 1.4 million, and 75% live in Africa and Asia. Childhood blindness accounts for less than 4% of global blindness. However, blind children has a longer life expectancy. Therefore, it is actually more of a burden because, I mean, I'm not saying that it's okay for the elderly, but then it is a very big issue for children if they are blind. And if we don't do, I mean, if we don't prevent or treat it as earlier. It can, I mean, blindness in children can be defined as a visual acuity of less than 360 in the eye with better vision in the child under 16 years of age. So what does that mean? This means that a child with normal vision can see the letter E, right? Can see the letter E at 60 meters, whereas a visually impaired child can only see letter E at 3 meters. Okay, that's the meaning of 3/60. They have to come nearer. This is the letter E. They have to come 3 meters to be able to see the big letter E. However, a child with no visual impairment can see it at 60 meters. All right. So that's, that's what it means actually. Okay. The causes of childhood blindness, it can affect any part of the eye. It can affect the whole globe, 36%. This is the cross section of the anatomy of the eyeball. It can affect any part of the whole globe, cornea, especially, usually during, in trauma cases, and lens, cataract, and retina. all right, the nerve of the eyeball, and of course the optic nerve, which connects it to the brain, and uvea. This is the area of the uvea. Grossly, you can only see from the cornea, okay, but for ophthalmologists, they need to dilate their eyes to be able to see the retina, to see what's going on there. All right, so what are the causes of childhood blindness? The prevalence and causes of pediatric blindness actually is based on the socio-economic factors that limit prevention and treatment schemes. In low-income countries, you still get corneal scarring from measles or vitamin A deficiency, as is shown in this picture. This is the beetle spots in vitamin A deficiency, where there is keratinized sclera, all right, that can lead to dryness of the cornea and can lead to abrasion, corneal abrasion, or scratches in at the cornea, which can lead to a corneal ulcer. And this can be a track for infection to set in. And this can lead to scarring, right? It becomes, scarred, and this is the result, okay? All right, now the second one, the other reason will be, the other cause will be ophthalmia neonatum, which is characterized by conjunctival pus discharge, yeah, within 1 month after birth. It occurs during the birth process. It is characterized by the copious pus discharge, swollen eyelids with red eyes, sometimes associated with fever. The other cause of blindness will be rubella cataract. Okay, cataract, rubella cataract is usually, because infection of rubella. However, cataract is also, cataract as a whole is also it is a treatable blindness for the children, whereby we can remove the cataract, implant intraocular lens, and the child can see again. It is, if you see it, it looks like a white eye, leukocoria, and the child cannot able to focus the objects. Therefore, early surgery gives good visual prognosis, and late treatment results in permanent blindness. Cataract is something that is a treatable blindness. It can, other than infection, it can be due to hereditary as well, or just idiopathic, all right? Now, another one is congenital glaucoma. It is rare. It is 1 in 10,000 birth. It is characterized by photophobia. Photophobia means glaring. The child can't see, when there's so much light, they tend to feel very glare. Cloudy cornea, okay, cloudy cornea, and ophthalmos. Ophthalmos, that means the eyeball. It is a big, it comes from the word bull's eye, so the eye is big. So this one is urgent referral to the ophthalmologist. If you notice, this baby, the eye is bigger, right? And this one as well is the right eye. So you have to be aware of all these problems, yeah? Now, in Malaysia, in developing regions of the world like Malaysia, the main reason of visual loss is retinal disorders, which accounts for 33%, and it's mainly retinopathy of prematurity, which is 17.4%. It is quite similar to developed countries as well, like the States, where one of the leading cause of blindness is retinopathy of prematurity. So this is good in the sense that it reflects the expansion of neonatal services in Malaysia and improve survival of very low birth weight and preterm babies, and expansion of maternal services in Malaysia. So other than that would be cataract, pseudophakia or phakia, which accounts for 17.2%, and anomalies affecting the whole group, 19.2%. Most of the etiology is undetermined, 43.1%, because the study that was done by D.K. Patel et al., childhood blindness and severe visual impairment in Malaysia, because it is from the residential blind school and also integrated blind school, therefore, sometimes the history, we cannot really, get it, because it's like they come, they're already blind, so we don't really know. That's why the etiology is undetermined. Other thing will be hereditary factors, mainly retinal dystrophies, is about 21.7%. Perinatal factors, 20.5%. 7.6% is potentially preventable, okay, like trauma, for example, okay, and 42.9% potentially treatable, like retinopathy of prematurity, cataract, congenital cataract. Okay, let me talk about a bit of retinopathy of prematurity, because that's the leading cause of childhood blindness in Malaysia. So retinopathy of prematurity is defined as abnormal retinal development in premature babies, whereby the stimulus for the abnormal growth comes from peripheral immature retina. It is higher risk in premature babies, less or the same as 32 weeks. It weighs less than 1,500 grams. Therefore, early detection and effective management can prevent blindness in retinopathy of prematurity. And how do you do that? Okay, let me explain a bit. Now, this is the cross section of the eyeball. In a normal child, normal baby, okay, without retinopathy of prematurity, the blood vessels grow normally. All right. However, in retinopathy of prematurity, there is an abnormal growth. There is interruption of the abnormal growth, which results in abnormal vessels. This abnormal vessels is very fragile and it can just break and bleed. Okay, so usually what we want is to prevent this from happening. Therefore, that's why screening is very important. Now, how do you classify this ROP? The latest international classification of retinopathy, ICROP, that was published in 2005, we divide this ROP based on the zones, okay? Zone 1, Zone 2, and Zone 3. Okay, so you must know, like, where does the ROP happen? Is it at Zone 1? Zone 1 is worse, all right? Or Zone 2 or Zone 3. Okay, so this is what we see when we dilate the eyes. Stage 1, demarcation line. It is characterized by this line. Stage 2, the ridge. Ridge means from the line, it becomes a ridge. It grows up, further up. And stage 3, where the blood vessels have gone into the vitreous. At this stage, we need to treat. We need to laser. And plus disease, which is characterized by dilatation and tortuosity of the vessels. Now, how do we screen? Early intervention, all children, birth weight less than 1,500 grams, gestational age at 32 weeks, meaning the baby is born at 32 weeks or below. We have to screen for retinopathy of prematurity. Or if the baby has undergone a very stormy birth and stormy NICU, right, with many disease and a lot of complications. So even if they don't follow this criteria, under the discretion of the neonatologist, we also screen them. So this is how we do it. That's me with the binocular indirect ophthalmoscope, and we see it through the lens, okay? And if we need to laser, yes, we do laser. Okay, this is the laser machine and me doing the laser, and this is how we do it. The spots, right? White spots. Now, other causes of blindness, which is very important, okay, but maybe it is not devastating. It's just either you tackle it earlier or late, right? Other things would be refractive error, myopia, or short-sighted, whereby near vision is better than distance, or hypermetropia, long-sighted. Near vision is more difficult than distance. It can cause headache with near work and astigmatism. All right, so what happens is that the light goes into the eye, and here's the image, light goes into the eye, goes into the lens, and then it's projected to the retina. However, in nearsighted vision or short-sighted, the light goes into the lens, but it falls in front of the retina because the eyeball is longer. So you need corrective lens, the concave lens, to see clearly. However, in far-sighted vision, long-sighted, yeah. So what happens is because the eyeball is shorter, the image falls behind the retina. You need a concave lens to focus it on the retina. So you need optical correction with glasses. You can use contact lens or needs regular visits to the optometrist, and if uncorrected may cause amblyopia or lazy eye. How does amblyopia occur? Uncorrected refractive error at early stage, or squint, strabismus, ptosis. Ptosis is droopy eyelids, congenital cataract. Therefore, early detection and early treatment will give good visual prognosis. So amblyopia, you can use a patch, okay, to, like, for example, this is the better eye, this is the lazy eye. So, sorry, this is the better eye, this is the lazy eye. What you do is you patch the good eye, you know, to stimulate the worst eye to see. All right. Now, another one is strabismus, squint. Is any misalignment in the eyes. About 4% of the population has strabismus. It often occurs in normal children. The disorders that affect the brain, such as cerebral palsy, Down syndrome, hydrocephalus, and brain tumor, are more likely to develop strabismus. Now I'd like to talk on the early intervention. I mean, what we do, our programs by the Ministry of Health for preschool children. One of it is AVIS, amblyopia and visual impairment screening. It is a branding of previous preschool vision screening activities conducted by the Ministry of Health optometrists. It is nationwide, a vision screening program led and run by the optometrists of the Ministry of Health. It's a collaboration with the private optometrists as well to increase screening coverage and also spectacle provision. So our objective is to standardize equipment, tests, and referral procedures to detect amblyopia and visual impairment, improve quality of preschool vision screening and from planning to evaluation, and of course to strengthen public and private partnership in prevention of amblyopia. And most important thing is to promote awareness, okay, about amblyopia and visual impairment among children, parents, and teachers. So this is the chart, private optometrists, AV glasses provider, AV screener. We are the AV screener, okay, and then you can have the independent screener as well. So the role is to detect, refer, and treat, and prescribe, okay, as early as possible, because if not treated, it will lead to permanent visual impairment. So it's a very important issue to address. Now, this is a paper done by Dr. Duratul Hussain. It's a profile of functional amblyopia cases seen by optometrists in the Ministry of Health in Malaysian hospitals. It's a 6-month study, and it is noted that 301 children diagnosed with amblyopia, and main cause is just refractive error. That means it's just because they don't wear glasses. So it is very important. I mean, AVIS is, preschool screening is very important. We need to do it. Most people are not aware, okay? Now, this is what they've done from 2016 to 2018. They haven't done the 2019. So if we notice in the numbers keep increasing, yeah? From 2016 to 2018, from 4,742 to 5,202, all right, 5,202. And you can detect about 20%, 25%. Every time you detect, it'll be about 20%, 25%, it'll be refractive error. Okay. So 83% of the children referred have significant refractive error. So it is a big problem. So this is the activities when they do the preschool screening for
Dr.
children.
Fazila, sorry to interrupt. You have 2 minutes more, yeah, please?
Yeah, I'm finishing, yeah. So for children who cannot read, they show matching pictures. All right, so this is retinoscopy we're doing. Okay, now what about school children? We also target for school children, mainly for year 1 students. Okay. Vision screening in year 1 student. So this is to foster cooperation between state education and district education department. So our target is vision more worse than 612, number of students with poor vision and number of students enrolled in year 1 times 100, our target is 5%. Now this is what we have achieved. All right, we always reach it, okay? This is how we do it, yeah? This is the activities. So in summary, children are not aware of their visual problems, so watch out for screen, frequent closure of one eye when looking at objects, head tilt and face turn, looking at objects at very near distance, and any complaints of seeing double images with headaches or blurred vision, avoidance of bright light, tearing and rubbing of eyes. My take-home message is beware of children's eye condition, see an ophthalmologist when you are in doubt, early detection, safe sight. With that, I thank you. I'd like to acknowledge Dr. Siti, Public Health Specialist, and Dr. Duratul Ain, also Puan Nuraini, optometrist from HTAR. Thank you very much.
Thank you so much, Doctor. That was a very good introduction of, or rather in education into issues for children's eye care. In fact, the topic of eye care for children is something close to our hearts as well. Every year, besides this conference, we have what we call a Sayangi Mata Vision Clinic, which it converted to English, it actually means taking care of your eyes. And we've been doing that for a few years already, where, of course, we screen everyone, but with particular emphasis for school children, especially in what we call the B40 group in Malaysia. These are the people who are not fortunate enough to have access to regular eye care. We'd like to play a video now to talk about, or to showcase what we've been doing in this. Over to the video, please. Sorry. Before we go to the video, yeah, you're right. Please put up the thank you. We'd like to offer a thank you to Dr. Fazilawati. We will be sending this through the mail in physical form. So thank you, Dr. Fazila. And now over to the video.
My pleasure.
Okay, thank you for that. I'd like to now introduce the next speaker. This is someone that I have had the pleasure of meeting myself. The last time he came down, Dr. Kula and I had lunch with Peter Ashall. Peter is going to call us from his home in the UK now. He's got a PhD in electronics, has spent his career in senior roles in telecoms industry, mostly for Motorola and Nokia. Recently, he's been involved in running and advising startup businesses and is working with various charities. One interesting charity that Peter sits on is to combat loneliness amongst the UK's aging population. So that's a very, very nice thing that you're doing there, Peter. Peter has got an active family life with the recent addition of 2 grandchildren. But today he's going to talk to us about use of technology in this area. Peter, over to you, exploiting smartphone technology for visual impairment. Dr. Peter Ashall joining us from UK. Over to you, Peter.
Surinder, thank you ever so much for that introduction, and welcome to you all. And such a competent and accomplished audience. It's a real honour to be able to talk to you. Just a couple of reflections, really, on what we've seen already. And I just love the way you talk so calmly about remarkable stories of transformation, of people's lives being completely transformed by this sort of amazing work that you're all involved in. And as Surinder said, it's as a new grandfather, to hear the care that you're taking with young children around the world and giving them a chance for a full life. It's just fantastic. And so I'm coming to you with a little story of technology, which in comparison, I think is not quite so shattering and world changing. But I have a question for you, and my whole purpose of this presentation is to ask you a question. One person in particular I would like to give great thanks to, and that's to your chairman, Dr. Kula. Dr. Kula has been a tremendous supporter of the work we've been doing with our little business. He's crossed the boundaries of technology, of eye health, of the legal world, of the governance world, with such incredible patience and calmness, and has really helped in the introductions, particularly to meet a number of you in Southeast Asia. And I'd just like to thank those of you I have met for your hospitality and consideration in the meetings, and the friendship that's been shown in the past. So what I would like to do, without further ado, is run through a little presentation I have for you. And Surinder, I will attempt to do this fairly quickly so we can move on to other parts of your agenda. My history is in telecoms, and many years looking at how this business grows. But I've been particularly aware over the past few years that really this industry has not done a great job for people with visual problems, mainly focusing on how to bring the latest, most exciting technology, presenting it to people in lots of different ways. So the title of the talk was exploiting smartphone technology for visual impairment. But I felt really this is about empowerment. This is about what can technology do to bring support, help, and open doors to people with visual disabilities. And this is how this next few minutes is going to go. It is actually rocket science. It's rocket science plus, as I would call it, but everybody has it. The question I want to ask is how we use it today, and what does this rocket science offer to those who really need it? And then the question is, what if? And I'd love to hear your thoughts and guidance on where we can take this little business that we've started. So this power we have in our hands with smartphones, it really is rocket science. And I want to draw a couple of comparisons for you, which will hopefully stimulate some thought and ideas. 50 years ago, man landed on the moon, an amazing achievement with the technology that was available. And if we compare the technology that was available then to now, we can draw some remarkable conclusions. For those of you who are interested in technology, there's about 1 million times more memory in a phone today than there was on the Apollo computer, the one that landed on the moon. And there's more than 7 million times more memory in an iPhone, which stores the working instructions, than there was on the Apollo guidance computer. That little phone in your pocket has over 100,000 times more the processing power of the computer that landed man on the moon 50 years ago. And you could probably simulate the flight of Apollo 11 on your handset and still not use more than 1% of its processing power. So what we have in our hands, I'm sure everybody on this conference has a smartphone. What you have in your hands is really rocket science plus plus. The smartphone is a global, ubiquitous platform. It is everywhere. There are more than 4 billion smartphones in the world today. There are more than 1.4 billion smartphones sold every single year. And the value in sales to the global product companies is $360 billion US. So here we have one of the most remarkable opportunities to put real value into many people's hands. And by real value, I mean putting tools in their hands which can really help their lives. We're very fortunate as a company to have signed a partnership agreement with Samsung, which is one of the most advanced technological companies on the planet. And through that partnership, we can take the sort of features and functions and what we've been doing onto a global scale. So what do we do with this amazing technology, this rocket science plus plus? Well, this thing that took us to the moon, we play games and we take pictures of food and we take selfies and we send emojis to each other. That's what we've designed into this rocket science. We also do more serious things. We are out to search the internet. We can search information on our health. Particularly with COVID today, there are some good tools which are now coming onto smartphones which help track and trace, and hopefully we'll get this thing under a degree of control over the next months. We can use WhatsApp and WeChat, we can communicate with each other, and we can use Zoom like this to talk face to face. It's quite remarkable listening to the first presenters, and you really do feel as though you're having a one-to-one conversation. So it's a remarkable tool which we use lightly and we use seriously. So what about accessibility? What happens if those tools that are available and those features and functions really don't quite work for you? Well, deep down in the operating system of phones, and Surinder, as someone who's worked in the industry, you'll know this well, there's all kinds of accessibility functions. When you compare the way they're presented, here we go. Somewhere deep in the settings, you'll find accessibility. And those of you who are in ophthalmology, I'm sure you're well aware of this. Then deeper down, you can find all kinds of things. But someone said to me once, the problem with accessibility on smartphones is that it's not very accessible. And so a little analogy I'd like to draw for you. If you consider this is a picture of some computer code. And we'll liken the computer code to the accessibility settings in a smartphone. And what I'd like to tell you is that this piece of computer software actually is describing this. What we want to be able to do is to transform accessibility from what it is today, which is a complex, difficult to understand, difficult to use computer code, into something as simple as a visual or an audible or a tactile cue, which is much more understandable. So what if this rocket science plus plus was turned and tuned to those for whom it's not currently useful? Well, let's say I actually wanted a triangle and I'm going into my smartphone to find a triangle. I can pretty much guarantee that because of all the complexity and the difficulties, you'll find something like this. This is the well-known Penrose triangle. It's a graphical image which can't even be built. It's an impossible object. But that doesn't really help me if I'm looking for a triangle. What I really want is this. And the transformation we want to make with smartphones today is to make accessible the sort of things which are not accessible. And what are the requirements for this to work on a global scale? Well, the most important thing is that it is fit for purpose. And to be able to talk about this to such an accomplished audience allows me to ask the question, which I'll come to at the end. It needs to be globally commercially priced platform. That remarkable story of the $4 lens. It's just incredible to hear how once you start to democratize technology, you can have an incredible impact. It needs to be available on a global scale. It needs to be set up easily. And also, smartphones are advancing rapidly with technology. And this technology needs to be presented to everybody, not just those who have 20/20 vision and are aged between 25 and 45. It needs to be for everybody. So what have we been doing with our little business so far with ZoneV? The challenges we're looking at are physical challenges, which are visual, oral, and challenges of dexterity, and mental challenges, which are ones of complexity, and particularly as people get older, I think this was mentioned a little earlier in one of the presentations, cognitive overload. Things become more complex, and the smartphone manufacturers delight in introducing complexity into their devices. And here we go. You're all familiar with this. This is the standard smartphone interface, usable by many, not usable by a lot of people. And what we're looking to do is to transform this first at a first level into something which deals with the visual, oral, dexterity and mental challenge that smartphones pose. Just to introduce some of the design principles. It's a very simple layout. It's visually very simple. We don't use pinch and zoom because people with arthritis can't do that. We use large text, so it's easily readable. It's very easy to set up and configure. And with this, you can access and run any app that a standard phone can offer. And we're introducing specialist functions for particular conditions, and in particular, various kinds of eye conditions. We can produce an interface which is very, very simple indeed. We have an interface which is effectively a screen reader, so anything which appears on the screen is read out to the user. We've been working on advanced image processing, so this means that objects outside the smartphone, not just the apps that appear, become more readable. And some of you may recognize this is the standard unreadable British Rail train ticket. So with some of the advanced processing we can use, we can do some very simple zooming into smaller objects. And we're looking also at some pretty advanced video processing, which allows you to change colors as well, making them much more readable. So these are just some of the simple things we've done in our first iteration. This is available on Samsung smartphones globally already. And you can download it from the Galaxy Store for those of you who have a Samsung phone. So here's the question that I alluded to, and this is really the important piece of this presentation. And to those of you who are absolute experts in this field, if I was to ask you the three things that were top of mind with this technology, which is 100,000 times more powerful than the rocket that went to the moon, and it's in the hands of many, many people around the world, what would you like to do with it? I'd really love to hear your thoughts on what this little device which sits in people's hands could do if you were able to influence its development. And if I can offer you my email address or the email address of the organizers, I would love to hear from as many of you as possible. What are those three things that don't appear on smartphones today, which will really help the people that you are bringing eyesight to, your patients and your clients. So if you could give some thought to that, I'd really love to hear where we could take this next phase of our development. We're looking at our next stage of development right now, and I'd love to think that through this conference, some really serious and thoughtful influence could be brought to what we're doing. So I'd like to thank you all for this opportunity to talk about what we're doing, and to hand back to you, Surinder.
Thank you, Peter. That was a good look at how technology could be used in this area. And it's nice to see you using simplification rather than all the complexities that goes into one of these that all of us carry. For those who are listening in to us, if you would want to get in touch with any of the speakers today, Peter or those before him and after him, just let us know. We'll be putting up some of the information here and we will help you get in touch. Peter, please accept our gratitude for the time that you've dialed in this morning, setting aside your Saturday morning. Thank you so much.
My absolute pleasure. Thank you for the invite.
Most welcome. Thank you. Let's move on to the next speaker, who is also from Europe. This is Miss Helene Durand, and she's going to speak about a Rotary Global Grant project in Cambodia. A little bit about Miss Durand is that after initial business school, she's been working in ophthalmology industry for more than 30 years as both a national and an international sales manager. She dedicates all her free time to the association Paul-Ayou du Monde, and I will allow her to explain what she does in that. Over to you, Helene Durand from France. We can't hear you. I think you're on mute.
Lower left where the mic is, just unclick it.
Raj is helping her.
Helen, you're not on mute, but your audio is not connected.
Oh.
Can you see the icon on bottom left, the first icon? You got to connect to your audio. Yeah, you're connected now. Can you say something, Helen? No. While waiting for Helen to connect to her audio, we'll play a video first.
I got this feeling inside my bones. It goes electric wavy when I turn it on. All through my city, all through my home. We're flying up no ceiling when we in our zone. I got that sunshine in my pocket, got that good soul in my feet. I feel that hot blood in my body when it drops. Ooh, I can't take my eyes off it, moving so phenomenally. You're more like the way we rock it, so don't stop. And under the lights when everything goes, nowhere to hide when I'm getting you close. When we move, well, you already know. you when you dance, dance, dance. Feel good creeping up on you, so just dance, dance, dance. Come on, all those things I shouldn't do, but you dance, dance, dance. And ain't nobody leaving soon, so keep dancing. I can't stop the feeling, so just dance, dance, dance. So just dance, dance, dance. Come on. Ooh, it's something magical. It's in the air, it's in my blood, it's rushing on. I don't need no reason, don't need control. I fly so high, no ceiling when I'm in my zone. Cause I got that sunshine in my pocket, got that good soul in my feet. I feel that hot blood in my body when it drops. Ooh, I can't take my eyes off it, moving so phenomenally. You're more like the way we rock it, so don't stop, stop, stop. Under the lights when everything goes, nowhere to hide when I'm getting you close. When we move where you already know, so just imagine. Nothing I can see but you when you dance, dance, dance. Feel good creeping up on you, so just dance, dance, dance. Come on, all those things I shouldn't do, but you dance, dance, dance. And ain't nobody leaving soon, so keep dancing. Can't stop the feeling, so just dance, dance, dance. So just dance, dance, dance. Stop the feeling, so just dance, dance, dance. Can't stop the feeling, yeah. So keep dancing.
Okay, due to a technical issue, sorry, I need to unmute myself. Hello everyone, due to a technical issue on Miss Helen Duran's end, we are going to try to sort that in the background, and we will.
Can you hear me? No.
Hello?
Hello?
Hi, we can hear you now.
Yes, I am on the. Oh, I'm not on the computer. I am on my tablet, on the iPhone, the Apple tablet. Can you hear me?
Yes, we can hear you. Please continue.
But I need your help because you know the presentation. I have not it on the Apple book. Can you send it for me or not?
I think we can. Yes.
You can do that for me?
Raj, can you show the slides for Helen?
Yes, I can, but Helen, you need to email it to me.
Are you sure? Okay. All right. So, Helen, can you hold on? We're going to move to the next speaker and then bring you in because we have to get the slides in the background. So please give us 15 minutes. I would like
now. Thank you very much. I'm very sorry. I don't understand why it doesn't work.
All right. Not a problem.
Mystery of technology.
Indeed. Our next speaker is from Singapore. Ms. Charity Y is the COO of the Singapore National Eye Centre and a board member of the ASEAN Association of Eye Hospitals. She's going to talk to us about blindness prevention in ASEAN countries. This Y has over 30 years of healthcare management experience and was a key member of the pioneering team that was tasked with the design and the planning of the Singapore National Eye Centre when it started off in 1990. Over the years, she has been an architect in developing and expanding the observational management structure in SNEC, Singapore National Eye Centre. She's also successfully led the admin departments as well as the clinical departments in various organizations. And for all her achievements, she has been awarded the Singapore President's National Day Award, Public Admin Medal, Bronze, and also the Sing Health Distinguished Leader Award, where she was recognized as a champion of change, and SNEC Silver Jubilee Pioneer Award. For her regional and international contributions, she was the recipient also of the International Award for Prevention of Blindness by the Asia Pacific Academy of Ophthalmology. I would like to hand over now to Ms. Charity Y to talk to us about blindness prevention in ASEAN countries. Over to you, please.
Thank you. Thank you for the kind introduction. Am I supposed to move the slides myself?
Yes.
Okay.
I understand that you have changed your topic. Is that correct?
Yes, I will bring on the
Please introduce
slides.
the topic that, yes, thank you.
Okay, thanks. Yeah, good afternoon, everyone. I'm so pleased to be here, and thanks for the kind introduction again. I bring greetings from the Singapore National Eye Centre, the ASEAN Association of Eye Hospitals, and the World Association of Eye Hospitals. Yes, as the MC was saying, yeah, I decided to change the topic. Originally, I was asked to talk about prevention of blindness in ASEAN, which of course is an important topic also. But since we are all in the midst of COVID-19 still, I felt that I'd like to really talk a little bit about COVID-19. What is the impact on ophthalmology, and what is it that we can expect for the new normal? So let's relive a little bit of our COVID-19 journey. As all of us remember, I think January this year, we are all kind of still living our life very normally. I think for us Chinese, we celebrated our Chinese New Year also in a usual way. But lo and behold, the next month in February, that's when our government in Singapore declared DOSCOM orange. So we escalated the emergency preparedness level. And I still remember that one evening in February, we were all asked to attend an urgent meeting in Ministry of Health. And the next day, we already have to start setting up screening station in the hospital already. So we had to screen the visitors, we got to screen the patients with travel history and all that. And very soon, of course, we started the disease outbreak task force. And of course, we need to meet every day almost to talk about what are the measures that we need to put in. And again, all of us who are living through the COVID journey will also remember, even in the business and industry, we all have to go into split teams. We all went to team A, team B, because we want to make sure that we segregate our staff, that we're prepared for business continuity. So that's what happened in a hospital. Hospital also that we also have our staff, nurses, doctors, and so on, all into the two different teams, so that again, we keep them separate and keep them safe. Then very soon in April.
Are you sharing your screen? Because we cannot see any slides.
Oh, sorry. You haven't seen my slides yet. I'm sorry.
No.
Shall I? Can you see it now?
No, we see your image only, not your screen.
Oh, I see. Now?
Yeah, it's coming. Yes, we can see your screen now. Thank you.
You can see it now?
Yes.
Okay. So as I was saying, that this is our COVID journey. So in February, that's when we started the DOSCOM Orange, when we started the screening. In March, we went into split teams. And in April, I think we started talking about safe distancing and all that, which of course now is becoming part of our daily lives, that we need to keep, so-called the safe distance. And of course, work from home, again, is something that all of us, have got the experience now. But before COVID, I think none of us really felt that we are able to work as productively or effectively from home. But now that, again, COVID has taught us a very important and positive lesson, that actually many of us can really be able to work from home. And of course, going into the April itself, we also started many measures in order to reach out to our patients, because with the safe distancing, it means that we cannot see the same number of patients as before. So we are, of course, having a lot of different new models of care, which I'll introduce a bit later on, including, of course, delivering medication to our patients at home, because again, if they cannot come into the center and if they need the eye drops, we started the home delivery. So going into April, May, I think in May particularly, I want to pay tribute to our healthcare workers, especially some of our eye doctors, nurses, because of the number that of the patients that we are not seeing in the hospital itself. We therefore have the manpower to be able to volunteer into the foreign workers dormitory, because there's a big disease outbreak there. And we really want to pay tribute to those volunteers who were able to, in a way, put themselves at risk and yet trying to care for the foreign workers. And of course, I'm happy to say that after 3-4 months of volunteering, I think most of the foreign workers now are well, and they are able to now be going back to work. And also our healthcare workers are, of course, coming back to our hospitals to resume their duties. And of course, in the whole few months that we are in a kind of lockdown situation where we are also trying to care for our patients, we have developed a lot of new models of care, which I'm trying to introduce later on in the talk itself. We are now, of course, in June, July, that sort of a recovery period. So for a few months now that we have been trying to resume our activities, just like also in the business sector, you're trying to recover and going back to normal. And I would say that in our hospital, we're almost back to about 80% of our patient load. But we do find difficulties trying to see the same number of patients that we see before because of the safe distancing and all that we still have to comply. So because of all this necessity of the crisis, we also make it essential for us to come up with new models of care. So what did we do? We really have to respond to the crisis because of the lockdown. We try to keep our people safe and we try to keep the essential services running. As we say, we're now in the recovery phase. We're trying to reopen our clinics, our operating theaters and all that. And we need to have a plan in order to restore to ourselves to a scalable state and also using a phased approach. And what's important out of all this is that we need to renew, we need to look at the new normal. We need to use the lessons that we learned and the new patterns that we observe and see how we can really reimagine the future. I think that's the most important thing about how we can make the crisis in a way something that is becoming of an opportunity for us so that we can create a better future using technology, using new models of care. So what are the key shifts that we have observed? As I've said, yeah, we have seen a high adoption of digital services, AI and robotics. And I think just like the talk from Peter, he mentioned the use of smartphone, although we need to make sure that technology is not complicated. How do we use technology to help our patients? And again, we see the shift, number 2, towards remote working models. Again, we've seen that, and this is going to be one of the permanent feature in our new normal, I think. And number 3, we know that the word agile has been used many, many times now. I think we have been told to be agile in terms of how we should be more flexible, more adaptable in managing our crisis. And of course, 4 and 5, again, that growing appreciation of the importance of the social determinant in health. I think Dr. Ruit in Nepal showed it very well. I think it's not just tackling cataract, but you need to be aware of the socio-economic conditions of the people and how do we then create the solution that's workable in those settings. And of course, number 5 tells us that we need to really have a holistic approach. So again, not just really tackling a disease, but looking at how do we also need to address climate change and urbanization. So how do we apply all this in terms of healthcare? So in terms of, again, as we say, we need to move away from the traditional role. We need to shift more from the hospital-centric into community, and how do we serve the community and all that. All this means that we need to really ensure that our workforce is transforming. So we need to equip our workforce to be more digital ready and to be able to be adaptable and so on. So a lot of that got to do with how do we transform our workforce. And of course, we know that we need to keep our patients more in the community rather than all the time coming into the hospital premises. And so again, we have been developing a lot of the home monitoring apps, which I will introduce to you later. And also running virtual clinics, meaning that you don't see the specialist in person, but you still get the benefit of the specialist decision and so on. And the engaging of more community partners, just as here, you know, you all have this wonderful conference. Yeah, you are going to be very important partner for us in the community. And of course, digital ambassadors. I think, yeah, we know that our patients, especially eye patients, are elderly. They are not very IT savvy. So we need to have really ambassadors who help them to embrace the technology. As Peter said, technology is not good enough just by itself. It has to be accessible. So how do we make it accessible to the elderly patients? So this is a slide showing the usual clinical pathway. Our patients who are in the community being referred into the specialist clinic, they go through consultation, they go through tests, and then they go to pharmacy for medication. This is the traditional way that I'm seeing our patients, but we have to really transform using digitization. And you can see that in the different phases of their visit, we put in the different technology. So even before they come into the hospital for the pre-visit, we have all sorts of apps to help them to make the appointments, to help them to do pre-registration. And then when they are inside the consultation journey inside our clinic, we make sure that we help them with this virtual concierge, which I'll explain a little bit later, giving them educational material so that they know about their eye conditions, and also offering cashless payment so that our patients do not have to wait at the counters anymore to wait and pay. And of course, after the visit again, we have now, as I mentioned to you, delivering some of the medication to them. So again, they do not have to wait in the hospital for a long time. And of course, keeping them in the home and using home monitoring and engagement. So yeah, we're shifting patient care from really from the hospital setting to more in the community, and also to empower them. So we are going to introduce them with a lot more technology that will help them to really do self-monitoring. So in the pre-clinic setting, we are already looking at giving them questionnaire so that they can give us already the answers to some of their conditions, their history taking, and so on, so that we are able to you know, in a way help them in terms of cutting down their time in the clinic. And of course, we want to engage them to use the community optometrists again, so that they can do some of their tests and their visitors, their investigations, and again to cut down on the time that they need in the hospital itself. And of course, a lot of home monitoring and patient communication, which I mentioned that we're turning to the technology. So some of the examples of teleophthalmology, this is an app that we send to our patients, and once they receive the app, they can really do some very simple tests that will be on screen, that they are able to do it themselves quite easily. They send the results back to us, and then our doctor will then be able to give them a decision, a diagnosis about how the condition is, whether green meaning that you're fine, yellow means that, okay, you're about the same, you need to continue for compliance, and then of course red meaning that their condition may have deteriorated, so we need to make an appointment for them to come back. So using this system, the patients do not now need to always come back to the hospital for their treatment or their consultation, but they are able to then be able to be so-called stay at home, to be safe, and yet still have their eye condition being monitored. And then, of course, this is another app showing that how we can allow a patient to actually check their own power, you know, the degree that of your myopia and so on. So again, using this app, they can self-administer the test. They can see how well their eye is seeing, and also that they will cut down the time that they need in the hospital, because they don't have to do this test in the hospital anymore. So again, demonstrating to you how in the patient journey, we're trying to put in new ways of treatment, new ways of testing, right from even registration, where we have self-registration kiosks, so that again they don't have to go to the counter and have to do a transaction with a human, you know, so-called healthcare worker, but they can really do a lot of this self-help and self tasks. And then of course cutting down the turnaround time, making them to have the self-test, you know, in terms of vision. And if they have to come to the hospital for some of this complicated equipment that is not easily available in the community, they can just really do the test. After that, they can actually leave immediately. They don't have to wait to see the doctor. Again, we know that in Singapore, many times I think patients complain there's long waiting time, and that really they can then return to home, and in fact even not have to make payment, because they can be making payments through the internet and so on. And then the test will be given to the doctors to read, and then we can, by the test that is the eye conditions and so on, we can then inform the patient whether they are continued to be well, or whether they need to really come back for a specialist consultation. This is again showing you the teleophthalmology, again what I mentioned, that patients do not now need to present themselves into the hospital anymore. We can, just like this meeting, everybody can zoom in, the patient can zoom in, and they can then you know, have a consultation virtually with a specialist. Here you can see my doctor smiling, and the patient is also giving his eye condition, telling the doctors what is it the eye condition is, and then we'll be able to give him again the new instruction about what are the eye drops that he need to take, what are the precautions that he need to take, and so on and so forth. So again, although this sort of model, we think that before pre-COVID, maybe patients don't take to it very well, but actually when we do the patient feedback, we find that a lot of patients find that very convenient, because they don't have to travel, they don't have to have the hassle of waiting and all that, and they find that really this virtual consultation helps them in terms of monitoring their eye health and so on. And already we have got all these conditions, all the doctors waiting to start this video consultation, showing how popular and how effective it has been. Okay, so there's a lot to do with the clinical, but even for education, we find that, of course, again, COVID has disrupted a lot of these activities, and a lot of the classes, as we all know, cannot be continue. And so therefore, a lot of education has also been going digital, so that we have already an ongoing plan. How do we roll out the e-learning studio? How do we develop a lot of the materials into the digitized form so that education can continue? So in terms of patient education, similarly, the same route. Again, a lot of the materials have been turned into digital. They are now available on our website. We actually push it very actively to the phones to our patients if they're coming for appointments, so that they can learn about their condition and answer some of the questions and so on already before they even come into the hospital. But of course, any talk of prevention of pandemic cannot be done without really talking about the people. So the people, our healthcare workers, are really the heroes, I think, in this whole COVID episode. And we of course want to continue to protect them. We want to keep them continue to be informed and connected and engaged. And this is some of the things that we have done in SNEC. Making sure that we have the town hall and different communication sessions. And of course, we continue to pay tribute to our volunteer healthcare frontliners, and also, of course, setting up peer support work groups so that we can help them in terms of any of the emotional support that they need. In terms, of course, the workforce transformation that we talk about, we need to upskill, reskill our workers. A lot of these courses got to do with really digital health, analytics, and so on, because I think IT is really the way to go. And of course, we plan to have both digital and IT care ambassadors. As we say, we need to both help our patients as well as our own staff to be able to go on this technology journey. Finally, I think on the screen now you can see the two characters, Chinese characters, which is Wei Ji. It means crisis. And of course, the character on the left, Wei, actually means danger. And on the right, it means Ji, opportunity. So together, it means although there is danger in a crisis, but it also equally afford to us a lot of opportunities. We need to identify the gaps. We need to look at what are the opportunities for us to really come up with more innovative ways, more innovative models, and so that we can then have really good and effective impact both on our patients, our people, and also in terms of how we prepare for pandemics. I'd like to thank you for having me here again. I want to congratulate the organizers. In fact, you have actually taken indeed that crisis mentality of really taking advantage of the opportunity. So you didn't cancel your meeting. Instead, you make it an opportunity. I can see that this is a great conference. You've got really speakers from all over the world. And I'm so pleased to be able to be part of it. And again, I thank you.
Thank you very much, Charity Y. And we are very glad you changed the topic, actually, because it made something much more relevant. And this kind of cutting-edge technology that is in Singapore should propagate everywhere. So thank you so much for sharing. And it's great how you've turned it around. This is we will be sending you a certificate of appreciation, which is just a small token from our side. Thank you again.
Thank you. Thank you.
If Miss Helen Duran is available now, and if Raj, we can show her slides, let's go over to you, Helen.
Yes. Is it better?
Yes.
Okay. Okay, thank you very much. So I thank you very much again to allow me to participate to your convention and to present our very, very small association. Whose name is Pour les Yeux du Monde. So it's a French association, was been created in 2006 by an ophthalmologist who is Khmer and French at the same time. Can you change the slide, please, for me? And the following. Thank you. So yes, it's a French association, and The vocation of this association is to treat the ocular disease for the people who are living along the Mekong, who they have no possibility to go to the hospitals in Phnom Penh or in other places all around Cambodia. So we have Dr. Lim has built this hospital boat, which is equipped for consultation and surgery. The president is Dr. George, who is also an ophthalmologist. And today we have 170 members. We organize every year, since 14 years, around 8 to 10 missions, 10-day missions. And we made over 80,000 consultations and more than 10,000 eye surgeries. Our eye surgeries are limited to pterygiums and cataracts. For example, for glaucoma, it's difficult because this pathology needs a follow-up. We cannot do on the boat because the missions are always between January, February, and March. Then we organize the following missions between September and December, because the boat is going from Phnom Penh to Siem Reap, and it depends of the Mekong, because if we have no sufficient quantity of water, the boat is stopped. So we have a very short auction during the year. All the missions are composed by volunteers. We have 3 to 4 ophthalmologists. Some are surgeons, some are medical ophthalmologists. We have 1 anesthetist, 2 or 3 nurses, 1 orthoptist, 1 or 2 opticians, and 1 pharmacist. Yes, the following slide, please. So you can see our boat. We live on it. On the deck, we can. The people are waiting for the consultations, and we equipped the deck with all the equipment for consultations. On the upper part of the boat, we have our, let's say, dining room, and we have always 8 rooms equipped with 2 beds, and we live on the boats. on the lower part of the boat, you have the consultation, and then we have the operating room, and room is only for the sterilization. The following, please. So we treated the pathologies. The pathologies we are treated are medical or surgical ocular pathologies, as well as optical corrections. The medical consultation is realized on the boat deck, and that concern corrective glasses, conjunctivitis, eye dryness, glaucoma, pterygium, and cataract, from children to elderly people. Surgical cases are realized in the operating room on the boat. Opticians cut the glasses with the grinder, and the patients receive correcting glasses for a symbolic dollar. We can speak about a symbolic dollar because for very, very poor people, we give the glasses. We don't ask for $1. At the moment, Cambodia is 16 million inhabitants, and only 60 ophthalmologists. So Pour les Yeux du Monde is a structured association which is well organized and established since more than 14 years. The Mekong is a vector of communication, and more than 50% of the population lives on its shores. Our operating room need to be renovated, and some equipment is outdated, defective, or missing, because the equipments have a very hard life with humidity on the boat. Thank you. Our project through the Rotary action is to improve the quality and the safety of medical and surgical care. We have to do again the treatment of the ceilings, as well as partitions. As well as partition and floor. We have to do again the resumption of electrical circuits and lighting. On the boat, we have to overhaul the engine of the boat, and we have also to renovate the painting of the boat hull. Concerning the equipments, we need more cataract boxes. We would like to have a stretcher for the operating room, autoclaves for sterilization, because we had two who are, I think, definitively dead. We need a biometer for lens calculations, phaco devices for cataract surgery, and adjustable stools for the surgeons. Thank you. So a global grant from the Rotary has been done by Mr. Lelou, who is an actor of the Rotary in the south of France. And I would like to thank you very much for his very active investment for us. So he made a file with different Rotaries of the south of France, of Occitania too, as well as Belgium and north of France. And he organized a trip to Cambodia to analyze all the work to do on the boat. And he meets already all the Lacans companies, as well as the material suppliers. Next, please. So we calculate all the expenses for all these works, which represent more than $91,500. And through the gifts of the Rotary clubs, the Rotary districts, and the Rotary Foundation, as well as private sponsors, we succeed in having the requested amount for the expenses. So I would like to thank you again as well, and very strongly Mr. City, who helped me in participating in this event. And I really would like to thank the Rotary, who had a very, very strong action for us, and specifically Mr. Lelou, who has been he's very, very active for us. I thank you very much.
Elaine, thank you so much for sharing that global grant project with us. We ourselves in this part of the world, I know, are looking at mobile vans, we were thinking, but what you've done, a mobile boat, is very, very appropriate for the reality that is in Cambodia. So it's an inspiration how you put it across, and maybe some of us will reach out to you to ask for some help as well. Thank you, Helen. We'll like to send you a small token of our appreciation, which we will do after this. Thank you once again. We will now go on to very quickly the next speaker. And this is Mr. Kavin Thiran, or Kavin for short. He will join us from Ipoh. He's a young man, only 25 years old, and just last year graduated from law with from the University of Malaysia with honors in law. So we congratulate you, Kavin. Kavin is currently attached to Yunus Ali and Kam Advocates. The best thing about Kavin, which makes him most relevant about this particular day today, is he's actually visually impaired himself. So Kavin is going to teach us about Zoom in the dark. I hand you over now to you, Kavin.
Picture this, a dark room with absence of any sign of brightness and vision. A blurred and somehow lost feeling with a lot of anxiety in our mind. Maybe most of the people who are listening now perceive that as a sign of blindness. Thankfully, for me, after being blind for about 25 years, I think it's not. It's a beginning journey for many adult blind. And me, as a born blind, have not, thankfully, gone through that. But I understand the movement that all of you are heading now, which is to prevent the blindness among adults and the senior citizens. But here, I'm trying to bring all of you into another real journey of stories and the sociological aspect of being blind. And the word blind here is referring to not the absence of sight or any anatomical term. I'm referring to the experiential blindness, which accords the narrative more to the human experience, life hacks, and life stories of being blind. Thank you to the host for introducing me. Things have changed a lot. I'm now in University of Malaya continuing my master's in criminal justice. And now I'm coming through an iPhone mic on my closet here. And it's great for me to be here and to address the honorable Rotarians and all the people here. And my story as a blind person really started before I knew, which is 6.5 months in my mom's womb. And due to the excess of oxygen, I've been placed into an incubator. And it's a perfect mistake or negligible mistake by the medical practitioners to not look after the oxygen level that's traveling through me. And due to the excess of oxygen, I lost my eyesight, and I wasn't sure how blindness feel because I've been blind for my lifetime. It's like you can't really know what is the experience of being human because you're human for all of your life. It's an indescribable moment or presence. So for those who lost their sight after they use it or after they experience the being of sight, they can say that it is dark or it is an absence of something or it is lack or something. But here for me, it is a different story. and for most of my friends who are born blind, totally blind when they begin their life. There is no interpretation of darkness or light, and there is no any sense of absence of light. But the curiosity about the world and the amazement that I have for the things, people, stories, science around me had brought me to wonders. This time in history is so remarkable because now we are living in the edge of discovery and the edge of invention, in where every story have its own place. We can thrive, and regardless of disability, social status, the skin color, gender and sexuality, we are in this world telling our own stories. And I totally aware and understand that the stories that we tell about us really define our circumstances. So the stories that most people tell about the blindness is very narrowed and short-lived, which is the beginning of the life of being blind. So many other factors that contribute to the people who needs or who need to live without the sight. People may have lost their sight due to medical conditions, accidents, or any other circumstances. And after that, unless the world is inclusive, the society is expansive in their thoughts, the language is so profound and broad, the blind can't live with big respect. Now we have a very polarized society, and usually blindness is always identified with narrow negative perspectives that hinders potential growth. For some who are lucky like me, who had parents that cared and inclusively treat me, I can find my education and curiosity through my wonder and exploration. But it is not happening for many of my friends in respect. So being blind here is not limited to losing the sight or losing the capability of perceiving something. In my case, being blind means, first, the open access to expansive array of possibilities and sense. So when I say possibilities, is the need for me to master the technology that I'm using day to day. So the technology can be divided into life hacks, which required me to maybe, let's use the word substitute. So require me to substitute my ability, require me to substitute my sight for another life hacks that can let me do things easily. So how am I going to know what is going on around me? How am I going to know whether the glass is full? How am I going to know whether what am I doing is what I should do? All this will be answered through my life hacks, through my discovery, through my use of the other senses. Here in the world, we are often defined by our five senses or the physical experience. The so-called five senses is defined in the old age of science, but now we have come through in many facets and many multidisciplinary studies have proved that we have, in fact, many more senses than the 5 senses. I'm not talking about the superficial 6th sense or any such things. It is more about the tactile sense, which the blind use to read braille. The hearing that the blind use not to hear, but to read. It is not hearing. It is hearing if we perceive it so. But what the blind is truly doing when they are, in fact, using the screen reader is reading, just like how the eye performs. Talk to a neurologist and they will explain about a nerve called V1 that supposedly work for the vision, get adapted evolutionarily to work in listening things. And in this world, there is in nature, there is a thing called biomimicry. Biomimicry basically is a concept where we observe the nature, plants and animals, and also us, and understand what the nature are doing differently and absorb in our life. In that matter, there is this thing called echolocation, which some of the master blind echolocators mastered. Echolocation is a way of bat who do not use eyesight that navigate around the universe. So many blind person, mostly that I know, who lived in US and other Western countries, I suppose there are some echolocators who are living in here, the countries that we know, who can navigate around their place using sounds and clicking. So echolocation means you click your mouth to generate a kind of sound that reflects the environment around you by bouncing on things and materials that is positioned around you. So these are many, some senses from many senses that I can say that we have not explored. We have heard a story from a global TED stage about a person who have no vision of colors, but designed, with the help of scientists, of course, designed a system where he can identify the colors and combination of colors using musical note. So when he navigates around painting, or when he navigates around people who are wearing colorful shirts, he can hear a symphonic creation of music on his ears. So all this translates to something very profound that we often forgot, which is visual is not about eyesight. Visual is about how our brain, or the collection of consciousness, the collective consciousness, which is our mind, picture things. Just think about this thing. If I say an expert in neurology and an expert in neurosurgery are walking beside you and would like to talk to you. So this imagery of a neurosurgeon will give you a picture depending on your worldview. Many of you will picture a man, or maybe an old man, which shows your bias against women. Or many of you will picture a white man or a youth, which shows your biasness against other race or blackness. If I say there is a prime minister, you have a certain picture, which explains about your worldview, the biases, vulnerabilities, and your mind processes. So the visual is not really about our physical senses. It is more about how we design our world through our stories. There are many doctors and medical practitioners here, and usually they strive to grant their patients, or maybe for some like Dr. Oliver Sacks, they're confident and they're friends. The sense, or the part of their body that they lose. But for most of the time, people need the stories to be different more than the restoration of body parts or senses. Many might disagree, but stories have told us that this restoration and sense restoring takes time, laborious work, and processes. Going through that laborious time requires more effort and emotional strength, which many of the people who lose sight and other senses have not been given so much. Many of the attention and focus are given to this so-called physical restoration, and not much had been done to narrate a beautiful story around the life of these people who are going through unique experiences. Losing something, no matter sight or the loved ones, is something experiential. It can't be discussed in a unidisciplinary understanding. It is a multi-perspective, multidisciplinary approach that needs us not only to talk about the world of losing physical sense, but also the stories that we tell them about their life, or the stories that we tell the parents about their kids. Let me take about 4 minutes or 5 minutes here to just explain about another quality that defines the life of the blind or the life of the disabled.
Kavin, sorry, we only have 2 minutes more. Kavin, please.
Yeah, sure. Which is about inclusivity. I am an accessibility advocate by my passion, where I talk to developers, mostly web developers and app developers, on making app accessible and usable. And here, inclusivity and accessibility means when designing something, we really need to think about those people that I mentioned that they're losing or they have no sight. And by designing an inclusive world is something which is opening, this way of opening up world for many people, for the women, LGBTQ, the blind, the old, and the kids. So when we design something, we think the whole world, which have this whole population, which are not only the youth, young man, white man. So when we create our world for everyone, we are opening up the social barrier, the attitudinal barrier that the disabled are facing right now, which is considerably, comparably less than what they are facing in physically. That's why when you position a blind kid with all the other blind kids, they feel so happy until they forgot. Or they no need to forgot. They do not know they are blind until you tell them all around them who are not blind are using some kind of technology to understand the world far better. Thank you so much.
Thank you very much, Kavin, for allowing us to see how your world looks like or feels like rather. It was illuminating. You also covered a lot of areas which were also covered by Peter earlier and some of the other speakers. But what was most inspiring is you're such a clear speaker. It's great to hear that you are back at school, and we look forward to hearing more about your legal career as you go forward. Kavin will be sending you a small token of our appreciation as well. Thank you once again.
Thank you so much.
Now, we move on quickly to our next speaker, who is zooming in from Netherlands, from the World Association of Eye Hospitals. Allow me to introduce Mrs. Maaike van Zuylen, currently the global lead of the World Association of Eye Hospitals, where she has been working with the association ever since it was established in 2007. At first, there were only 8 eye hospitals participating, but through the hard work of people like Mrs. van Zuylen and her team, there are now more than 55 global hospitals which are part of this association, And they are a group of hospitals which exchange knowledge, exchange ideas. They're doing work on impact of COVID-19 as well. Mrs. Van Zuylen is going to talk to us about being an advocate for vision. Over to you, Micah.
Thank you very much. Sharing my screen. Let me change. I think now you see the PowerPoint slides.
Yes, we can see it.
Yes, perfect. Okay. So, dear all, good morning for myself, I think, and people in Europe. Good afternoon, good evening. To all of you that are attending from all over the world. Thank you very much for inviting the World Association of Eye Hospitals. Especially a large thank you to Dato Kula. He has been one of our board members since the beginning of the World Association. And you've just heard Mrs. Charity Y speaking. She's also on the Zoom meeting. She has also been one of our board members since the beginning. So thank you very much also to Mr. Citi for inviting me to speak. I'm Maaike van Zuylen. I'm the global lead of the World Association of Eye Hospitals. And I will share some insights to you about the World Association of Eye Hospitals. And of course, why are we doing this? Just 2 days ago, it was World Sight Day. And I think if you look at the facts, it's incredible. I think it's incredible number that 1 billion people have still a visual impairment that could have been prevented or is still to be addressed. I think this, well, this is actually an awful fact, and we are all of you people who are online attending, we should keep this number in mind. It's not 1 million, it's not 10 people, it's 1 billion. I think it's a sad fact indeed. But first, a little bit background of the World Association. We were established in 2007 by 8 eye hospitals, also from all over the world. You see Dato Kula on the left of the picture, Mrs. Charity Y in the middle, Mrs. Ruit from Ruit Eye Hospital, Thailand, she's there. So 3 eye hospitals from Asia, they actually established this World Association. But now we're like 13, 14 years further away in 55 members all over the world, South America, America, Asia, even in Africa. So that's a lot. And even a flying eye hospital. I think you all know Orbis. Beautiful eye hospital. Let me change this because I think you all see this too. So try to get that away. Yeah. So a growing, what are we all challenged by? A growing number of patients, physician, clinician burnout, lack of staff, budget is going down all over the world, new technologies, new delivery models, and there's a large need for innovation in screening. And I think the last thing, all eye hospitals all over the world, and not just eye hospitals, but I think all individual people, whatever you are doing, we are all challenged by COVID-19. The role of the, let me see, yeah, sorry. How do we deal with these challenges? What is the role of the World Association? We cooperate on a global level via projects, and we focus on topics like medical outcomes, but also patient information about enucleation. And how do we share this? We share this via webinars currently, white papers, virtual annual meetings, and we also have an online knowledge hub. And we learn from each other. That's the basic thing. We learn from, for instance, the Rotterdam Eye Hospital. They are implementing a Precise, that's a robot in vitro retinal surgery. We learn from Kuala Lumpur, the Tun Hussein On Eye Hospital. A few years ago, they already went into the community with a large bus. And for instance, the Rotterdam Eye Hospital, the picture on the right, they saw this very good idea from Malaysia, and they've implemented it in the Netherlands. Another example of what we do is we learn from each other via, this is an example of guide for using eye drops. for instance, you can develop that and write that in London, but you could also like copy it and translate it into your local situation and use it, for instance, in America, South America, or Asia. And one of our last projects was executed by the Royal Victorian, a very excellent nurse from Melbourne, Mitchell Wilson. He compared the patient information about enucleation with what they already had in the USA and London. And now we have a very large set of patient information about enucleation that can be easily also used by all the people that are currently online via Zoom. I would be very happy to share this information also with you, so please contact me later on. So we learn from peers. We learn from a European Association of Eye Hospitals. We learn from the ASEAN eye hospitals that are currently, I think a lot of them are online. And we also learn from the American Association of Eye and Ear Hospitals. So now a little bit about COVID-19. There was an urgent need to share best practices, and people in all the eye hospitals needed to maintain the essential care. So one of our eye hospitals has actually 3 eye hospitals in Wuhan, and of course they were the first who were experiencing the impact of COVID-19, and they are very, very transparent in sharing all their insights and lessons learned to all the eye hospitals from all over the world. So immediately when that happened, we started up some bi-weekly webinars to share information. A lot of eye hospitals were also in a lockdown. They just had the opportunity to provide emergency care. So this was, so what was the side effect? The side effect was that the implementation of innovations was speeded up. So people told me that what previously took 5 years, now just took 5 weeks. So that's, I think, something we have to keep in mind if you think about, back again, about the numbers. 1 billion people all over the world who are having a visual impairment, and we have not been able to solve that in a lot of years. So what if we, like COVID-19 has speeded up the innovation, maybe we can use those lessons learned now to also speed up or lessen down the number of people who have visual impairments. Some examples from Wuhan, you see a lot of personal protection, a lesson learned from the USA. They started up a drive-through eye checkup, evolution of slit lamp from Moorfields, never been used before, never needed, and then suddenly they had to make it. Of course, not just in London, but they also needed it in the United States. And a lot of VR drape evolutions. And also something that I think Mrs. Charity Y also spoke about, a lot of video consultations. So this is an example from Moorfields. They didn't do any or like minimal use before March. When March and the COVID-19 started, they went up to 350 examples every day. So that are incredible numbers. So what are the next steps regarding COVID-19? It's of course dependent on the local situation. The eye hospitals need to scale up or scale down dependent on the local situation. They have a backlog of patients they still have to take care of. And I think they have to, what is the idea is to continue to refine the virtual models, because that has been very useful in the first wave. And dependent, of course, of your local situation, you can also use this and also prepare for a potential second wave. And people have been, of course, working a lot, so they also need to take a rest mentally and also physically. So this is, I think, the next step for all of us that are online. So how can we use this COVID-19 speed of being able to innovate to lessen the burden of avoidable blindness and visual impairedness? And I'm still thinking about the 1 billion people. It's an incredible number. we should not just think about it, but we also have to take action. So I would like to offer the connection to all of you to the World Association Global Network to lower down these numbers. So how can we as a global network help you in the good work that you are all doing? And an invitation from the board of the World Association. In the upcoming months, we are organizing our annual virtual meeting. Next Wednesday and Thursday, the 14th and 15th of October, I would really like to invite all of you to attend our meeting. And the next phase is 11th and the 12th of November. Fully virtual, of course, this time. I was going to Malaysia and Singapore the upcoming week, but I'm very happy that I see all of you now virtually. So thank you, Dr. Kula and Mr. Siti, for inviting me to share some insight about the World Association. And if you would like to connect to me, here are my contact details.
Thank you so much, Michael. Thank you for that invitation. We will indeed be taking that up. Thank you also for sharing what you've been doing at your hospitals during COVID-19, using technology, quite similar to what Ms. Charity Y had just shared with us from Singapore. And so you have shown us even more evidence that it can be done. Your offer to help Rotary clubs will be taken up for sure by at least one or more of our clubs. We look forward to working with you. We will be sending you a small token of appreciation as you see on the screen, but thank you once again. We would now like to show a video. Raj, the video, please.
Been reading books of old, the legends and the myths, Achilles and his gold, Hercules and his gifts, Spider-Man's control, and Batman with his fists. And clearly I don't see myself up on that list. But she said, where you wanna go, how much you wanna risk. I'm not looking for somebody with some superhuman gifts, some superhero, some fairy tale bliss, just something I can turn to, somebody I can kiss. I want something just like this. Do 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 do. Oh, I want something just like this. Do 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 do. Oh, I want something just like this. I want something just like this. I've been reading books of old, the legends and the myths, the testaments they told, the moon and its eclipse, and Superman rolls a suit before he lives. But I'm not the kind of person that it fits. But she said, where you wanna go, how much you wanna risk. I'm not looking for somebody with some superhuman gifts, some superhero, some fairy tale bliss, just something I can turn to, somebody I can miss. I want something just like this. Oh, I want something just like this. Where'd you wanna go? How much you wanna risk? I'm not looking for somebody with some superhuman gifts, some superhero, some fairy tale bliss, just something I can turn to, somebody I can kiss. So I want something just like this. Oh, I
Those were video still shots from our vision. Thank you, Raj. We are now going to listen to Mr. Moses Chew. Moses comes from Penang. He was actually born visually impaired and spent his early childhood in the St. Nicholas School for the Blind in Penang. He then started work in Taylor's College. He started his career in a bookshop over there and spent 25 years in the corporate world. He's had several jobs. He's worked as a switchboard operator, tech support, purchasing assistant, and an admin manager. His last role was then as an admin manager for Tricor, which is a famous group of companies here in Malaysia. In 2002, he joined the National Council for the Blind as an executive officer of the Blind Professional Assistance Unit. He has now moved on and he is currently executive director at the National Council for the Blind. We're very happy to have Moses here with us today. And Moses is going to talk about voicing for the blind. Over to you, Moses.
Hello, can you all hear me now?
Yes, we can.
Okay, this is my slide. Is it showing?
Yes, it is.
Okay, right.
Oh, no, it's not showing, sorry. The slide.
Hold on. Okay.
No,
is it on now?
No, nothing yet.
Just hold on. Was showing just now, hey?
Okay, it's coming.
Is it showing now?
Not yet, Moses.
Hold on. Okay, on my side it's showing. Sorry, I don't know what's on your screen now.
It's like an image that's still loading. It's stuck. It's his image.
Okay, what about this now?
I'm afraid not, Moses. There's just still nothing there.
Okay, in that case, do I have a copy of my slide? You want to show it to save time?
Okay, you carry on speaking and Raj will start looking for those the slide back. Go ahead.
Okay, now this is on slide 2. It is my part. So as you have mentioned just now, that I'm employed under the National Council for the Blind. I won't be here for very long more, but I'm actually old enough to retire. But in the meantime, the next couple of months, I'll still be there. So my work is just to run the National Council for the Blind. Now, the National Council for the Blind is actually an umbrella of 5 organizations. And we are also connected to the rest of the world, especially with the World Blind Union, AZ Consortium. Right? Now, if the slide is on, you will see an umbrella-like image of all the different organizations together. Right? Now, who are we? The National Council for the Blind is an NGO, and it is a tax-exempted organization. I think that's all you need to know much about us. Okay? And after that is what we do. Now, the objectives of the National Council for the Blind, okay, is make life better for the blind. That is the main thing. Now, the functions. We coordinate with the government, and we coordinate with other organizations. We review rehabilitation needs, we review training needs. Okay. Now, let's look at some local scene. Actually, with 32 million of population in Malaysia, we should have about 320,000 blind people, right? But in actual fact, the registration is only 55,000 or so. And if we look at the working blind, okay, there are now about 10,000 blind people who are working within Malaysia. And again, you depend what is hold on. Okay, can you move on to slide 8? If you can, Rush. Okay, from here you can do. I can see a little bit, so I know what is it like. Here, these are the figures that I mentioned just now. All right, and then right, we move on to the next slide. The work. Okay, this is actually what we do at the National Council for the Blind in Malaysia. All right, we introduce technology, especially now. Okay, we bring in new ideas. Okay, we look at education, we look at training needs, and we look at access to technology, especially e-commerce. Just now you heard Kevin mentioning about access to information, access to apps, and access to the web. All right, then we move on to the next one. Right, now, what do we do in NCBN? Besides prevention of blindness, all of you are very well aware of, we actually also look at helping blind people to live through life, helping society to include the blind. So if technology is available, we use them, and this is how a lot of the work we do. Okay, in fact, it is not easy working in Malaysia because politicians have the biggest say, and we have to work with politicians, and we try to speak through politicians. Can we go to the next slide? Okay, what do blind people want? Blind people want to be treated equal. You heard from Kevindran just now. Okay, we want to be treated equally. We want to work. We want to be able to study. We want to be able to choose what we want to do. Very often, things are just thrown onto blind people and say, you use this or you do it this way. No, we believe there are options. And so, and we want to be able to be contributing back to society. Can we move on next one? Misconception. All right. It's because of misconception we are faced with lots of strange incidents. People always think once you're blind, you don't have money, or you're blind, you got no feelings. Right? Blind got plenty of feelings. We may not see, we visualize a lot. Move on, next one. Now, this is just information to give you a white cane. Now, a white cane is nothing. It is just a plain, simple stick that we can touch the ground with, and we know what we are touching. All right, and it gives us information. That's all we need a white cane for. A lot of Chinese during those days, after seeing too much about the blind swordsman and his foldable sword, I think, has lots of wrong images of what the blind can do and what the blind cannot do. They imagine a lot of things. I even have gone through days when I was selling biscuits on the road. A lot of the Chinese villagers would ask me the big numbers because they believe blind people got lucky fingers. And I used to tell them, well, if my fingers are so lucky, I don't have to come and sell things because I will be the richest man. Move on to the next one. Now, again, I want to show you, all we want to do is we need information. You would have seen all these tiles on the ground. I just want to explain to you a little bit. But for those of you who have been through other countries like China, even Malaysia, these yellow tiles have changed color to gray. I'm sure all of you know much about poor, do you call it what? Poor, the colors are not good enough contrast. So when you put gray on the road, it's almost like the color of the road. So a lot of them have changed it to gray just because they don't want, they find it difficult to clean something that is bright yellow. This house also doesn't tell us much. It just tells us two things. Notice there are two tiles. The left house is only a straight line. That tells us, tell the blind to walk forward. All right. So we walk following the direction of the tile. And then the next tile full of dots. These are called warning tiles. It tells the blind to stop walking, examine your direction. Then we decide to move on. We look for the next tile. The next tile, depending whether it turns right or it continues. We move on to the next slide. Okay, now a lot of people see buttons lifts that have Braille. Is this really useful? Well, if you have to navigate up a building with 100 floors, having 100 buttons to touch, by the time I touch the right button to press the floor, it may have passed the floor. So basically, a lot of people think giving Braille buttons is a good idea. Actually, yes, in a way it does, but it's not complete. We need audio as well. We need lift to announce what floor we are on. If not, you poke out your head and you ask what floor is this, then maybe no one to answer you even. Right? So I'm putting this picture just to explain to you. Some people put up these ideas, but this is not sufficient information. We move to the next slide. Okay, now I just want to show you, this was the beginning of actually artificial intelligence. Way back in the 80s, I think, late 70s and 80s, this machine was invented, and it's a reading machine. And well, those lucky enough to can afford it, at that time, I think it was more than 100,000 USD, enjoyed it prior to us. Now, all this information, all these facilities is put into a handphone. So artificial intelligence is on a handphone now. Can you imagine? Almost everyone has this machine now. Okay, next slide. Now, I just want to show you, I think this one, some of you may not be able to see it. I realized that after only sending you the slides, because you don't have the drivers for the Braille fonts. So I just wanted to show you what Braille fonts is about. Okay, next one. Okay, so this is where I talk about the way forward now is artificial intelligence. And basically, with a phone, you can tell scenery, you can tell, read, and you can even tell a person's age. If someone has an iPhone with you, all you need to download is a software called Seeing AI, and you should be able to do a couple of things that a blind can't do because they cannot see. You can see whether the lights are on, you can check what color is the clothes, or you can even take picture and see whether the person that you took a picture of is happy or sad or angry. Next. Well, I was told 15 minutes, but then I saw in the program was 5 minutes. That's the reason why I am cutting it very short. But basically, together with Kevin, we are trying to draw your attention to being blind. Yes, we face disadvantages, but the future is still bright enough. We can work, we can contribute, and we believe we can do much more than what you think we can do.
Thank you.
Thank you.
Thank you very much. In fact, thank you for giving us back some time, but also thank you for putting us in our place where we make certain assumptions about the blind, and you have opened up a whole new world for us. Thank you again. We will be sending you a small token of our appreciation.
Thank you. Thank you.
We're coming to the tail end of our seminar today. The next speaker is coming in from Jakarta, Indonesia, from the Asian Association of Eye Hospitals. We are very honored to have Professor Jayono Darminto Gondowoyarjo, who is currently a fellow of the Indonesian Academy of Sciences since 2008, a professor in the Department of Ophthalmology at the Faculty of Medicine, University of Indonesia, visiting professor at 2 universities, one at the University of Gajah Mada and the University of Andalas. He has also in the past been Indonesia's chairman has been the chairman for Indonesia's College of Ophthalmology and vice president for the Asia Pacific Academy of Ophthalmology, besides many other positions. Certainly a very distinguished gentleman. And he's going to talk to us today. We've heard a lot about blindness in children. We're now going to move over to eye diseases in the elderly. Over to you, Dr. Jayono.
Thank you. One moment. Could you see my slide? Hello?
Yes, we can.
Yes. First of all, I would like to thank the the organizer, especially Dato Kula, Dr. Pal, and Puan Siti for inviting me for this important World Sight Day 2020 issue. I'm copying charity, which is slightly changing the topic, which is elderly eye problem. But I would like to stress to the impact of the disruptive era. Some of my slides have been showing when I talked last year in Tone. When we are going to be old, elderly, so where are we going to? If we look here, we could see that actually when we are going old, we would like to have life satisfaction and life expectancy. And if we look, let's say Indonesia, Malaysia, Singapore, Thailand, Philippines, Vietnam, and Cambodia, all from the Asian country, we are still in the middle class, mostly except for Singapore and Thailand, and maybe Malaysia is under 50. But from the eyesight, we have a vision, that Vision 2020, the right to sight, is that we would like to be free from all the avoidable blindness, actually. And if we look in the aging process, now we could see that the aging process in the ASEAN countries also is being the highest. For instance, in Indonesia, in Thailand, Vietnam, Philippines, Cambodia, it's become more and more percentage of the aging population as compared to the previous situation. And when we talk about the blindness in the elderly patient, so the increase of longevity actually shifted. It is not merely due to the cataracts, but also because of the lifestyle, diabetic retinopathy, and glaucoma, and also the age-related macular degeneration. That will be the four main of the diseases of blindness, causes of blindness in the elderly people. But we know that when we move from the developed countries to the more developed countries, which means increase the longevity, there will be a shift from the pattern of blindness, which is mostly by cataract, and we shifted to the age-related macular degeneration, to diabetic retinopathy and glaucoma, rather than merely from the cataract. What is the impact of this blindness actually? We have heard that from the two blind speaker, it is totally different. Why? Because the eye or the visual actually play a role of the 83% of the information, daily information from our daily life. It means then when you are become dark, like the zoom in the dark, then it will be a real disaster. If we look in the world blindness and the moderate to severe visual impairment, we would like to see that the AMD become move to the cataract, AMD, and DR, and glaucoma. It will be, the percentage will be higher and higher in the situation. If you look here, yeah? So the movement of the causes of blindness will be much impacted to the biggest number in Southeast Asia region, especially when the area of the slum area, the discrepancy. And if we look in the impact of the surgery for the cataract, for instance, we could see that when someone told as a blind or even the moderate to severe blind visual impairment, we could see that the quality of life to self-care, mobility, and social mental is below 50%. But as soon as this cataract blindness got a surgery, they could see the world again. The quality of life is improvement of the quality of life is very enormous. And if you look in the productivity, after the surgery, even for the elderly over 60 years old, when only the first eye, there's already an increasing of who is working to the those who are not working is equal. But after the both eye have been operated, look at that, they become back to the productivity almost twice than they can work again, than almost twice than those who cannot work. And if you look in the utility value survey from in Indonesia, in one of our area, the willingness to trade to see again is about 60%, 67% to 95% as compared to the rest of their life. This survey is a bit difficult to imagine. That let's say that we ask someone how long he or she would like would like to stay alive if she could would like to see. Let's say if they said that I would like to see my daughter or my son to be married. Let's say how old are they? Let's say about 10 more years. So if they would like to change to trade off, let's say 97%, it means that 6.7 years they are ready to deal to see the world again. If it is 95%, it means that 9.5%, 9 to 5 years they would like to trade off to see the world again. This is to see that how desperate they become blind. And if we look in the effect of the blindness or the visual impairment to the person itself, its disability, suffering, loss of productivity, quality of life, and clinical depression, and of course become higher mortality risk. And it is for the person, but for the social, it has an enormous toll on family member and caregiver. And the economic impact is indirect cost, and cumulative effect is always underestimated by the population. If you look in the economic cost of the productivity loss to the blindness and moderate, we could see that it is related to the whether it is a developed country or a non-developed country. So it is related to the minimum monthly wage of the worker. So if this we compare to the US, for instance, so or China, Vietnam, or Bangladesh, so all in Indonesia, for instance, it is in the lower. So it can be seen that a blindness is cheap as compared to the developed country. Now, if we look in the aging process, it is projected that actually the percent of labor forces of over 50 years and older is always increasing. Why? Because there is an aging increasement of the aging population, and also if we look in the comparison of the aging population to the income level, we could see again that only Singapore, which is high, but most of the Asian country is low. From Laos, Indonesia, Thailand, Myanmar, Cambodia is actually very low. And on the other side, the working age population is increasing. Let's say Indonesia, Malaysia, Philippines are mostly about 67% population are in the working age group. It means that the availability, the possibility, opportunity for the aging population to work in the formal work is less compared to the developed to the blindness country. But if we look in the situation of how that actually the country look at the blindness, they would like to see here is the study from the Australia. It is compared that vision disorder to the year to date and health cost comparison is among the level of 5 to 7 of the top priority. But if you look in the real situation, actually, the relationship from blindness to socio-economic situation, to do with due my respect to the Mr. Moses and Mr. Caventran, that actually, if you go blind, it is more sure that you become poverty. But poverty on the other side might induce the blindness. So in this case, for the priority setting for the government, actually, it is not just cost effectiveness, but we have to see whether the poverty impact, the labor market productivity and welfare benefit should be things as beyond improvement of the health. If we look in the direct cost and the cost of suffering, actually for the cost of the treatable diseases, the hospital drug is, for instance, for cataracts is only about 18%. This is from the Australian, and the indirect cost is about 33%, and the cost of suffering is 49%. So it is very cheap as compared to the real cost if the government do things that they do not want to treat the blindness. The similar condition for the corneal transplantation, we can see that this is actually very cheap, the surgery itself. And as Australians said, that blindness and cancer are the two most feared health conditions. Now we are facing the COVID. This is, we see that disrupting area. Either we achieve the World Sight Day hope in sight vision, or we will go into the recession. It is things that we have to really have to concern about it. Why? Because when we look in the phases of crisis, there are two phases. This is the red one is cases without containment policy. And if we do containment policy, we try to lowering the number. But actually, when we try to lowering the number, we will having the economic aspect that there will be some, we could call that from the management side that it is a death valley. Death valley is how deep is the valley and how long is the crisis. And there are from the economic things that there are 4 type of letter with this economic recovery. The V shape is the best one. We look in this is the gray one is the condition of the recession. The U shape, the V shape, the W shape, and the L shape. Okay. Look at the South Asian economic growth. Nowadays, my country was the worst. It is still going up. Yeah, this is about 2 weeks ago. It's still going up as compared to Brunei, Thailand, Cambodia, Vietnam, Malaysia. But we always do not know whether there will be a second wave or third wave. If you look the projection of the Southeast Asian economic growth forecast, most of the new things that become red, except Brunei and Myanmar and also Vietnam become red. But in the highest in Indonesia, they said -1%, but I don't think it is true, but it might be higher. The prediction next year might be too good to be true. Let's say if you look in the million of the jobs lost, says here you could see that the projection that in Thailand, in Vietnam, Indonesia, Philippines, Malaysia, Cambodia, the number is very high due to the recession, the pandemic situation. And if you look in the comparison from the Greece, for instance, about 2019, but they actually get a recession from the last 10 years ago. We could see that there are very go to what I called the Death Valley, because let's say at the 14 they could not raising up. Why? Because the number of the proportion of the productive aging period is only about 43%. They have to bear about more than 57% of the aging population and the younger generation. It means that the worker capacity is play the main role for this issue. So back to the situation in my hospital, we have done most of what is Charity and Mike have talked about us. We could see that my hospital actually is a private hospital. It means that we have to grow up by ourselves. We could see that from this is we have always making good things, that the green one is actually the maximum number, and the red one is the minimum number, and the yellow is the end. This is all this kind of chart. We made it for the last 7 years, so we know exactly in which queue, which is the smallest gap within the minus minimal to maximum. Yeah, we could see that here the admission report. This is a big dip. So in April was the very deepest valley, and we have to try to improve, do all innovation to improve our quality of services, safety for the patient, and also encouraging the patient to come. What we have done, we can see the improvement of even for the cataract surgery, it is going up again. And in July and August, it means that even though within the still within the recession, the crisis we could improving. So in here it seems like a U, but on September we start to have a new large scale mobility avoidance. That it means that it is become drop again. So in September and October, it has become again dropping again. So we do not know whether we could have, whether we could improve again to the U shape, or we have to shift to the W shape. Okay. So
Dr. Jayono, we have 1 minute left, please.
Yes. Okay. So in view that in that situation, it means that all activity of the blindness treatable or avoidable will be in disaster. So in that point, we have to back to the principle that the family should become the real one. Because why? Because the younger generation, the productive have to work outside. We have to take care to the children, and the children itself, it's become safe. So we have to change the situation like this. What is happened that all the government try to please the younger, the elder one have to care to their father. Okay, so in point that if we look in the cost is always grew up. It means that we could not think that blindness situation, it is a cost. We have to starting to invest, to spend, to utilize to the future. You know that there is a Pareto phenomenon, which is 20% of the people get the 80% of the money. On the other side, the other 20% of the money only have to be divided in the 80% of the youngest population. So I would like to quote what is Jack Ma said, that the real business people make money by solving social problems for the others. I do hope that I believe that all the Rotary member actually thinks in the same way. So blindness or wellness, because the COVID recession and selfishness should be avoided by social responsibility. Otherwise, the blindness rate will become higher and higher. I think this is my last speech. Thank you very much for all your kindness.
Thank you, Dr. Jayono. Thank you. That was a very sobering description of the interplay between aging, the virus, and the economy. Thank you so much. Dr. Jayano will be sending you a small token of our appreciation. Ladies and gentlemen, we've come to the last speaker for today, and this person is coming to us from Singapore, Dr. Ho Sek Tian. He is currently a consultant eye surgeon in private practice, subspecializing in glaucoma and cataract surgery at Mount Elizabeth Novena Hospital, as well as Glen Eagles Hospital in Singapore. Before that, Dr. Ho was at the Singapore National Eye Centre, where he rose through the ranks as chief resident, glaucoma fellow and consultant before he left for private practice. He has authored over 80 scientific papers, and he is a reviewer as well, and in journals such as the American Journal of Ophthalmology and the British Journal of Ophthalmology. Doctor is going to speak today to us about making 21st century glaucoma care a possibility for all. Over to you, Dr. Ho.
Thank you, Mr. Chairman. First, I would like to thank the conference organizers, particularly PDG Siti Zubaida, for inviting me here to give the talk. I'm indeed honored to be first be here representing RC Singapore, as well as on a more personal basis to share with you some of my experiences here in Singapore. Okay, I'm going to share my screen now. Okay, my talk today is making 21st century glaucoma care a possibility for all. Now, the outline of my talk, I'll be speaking on what is glaucoma, how common is glaucoma, what is the burden of glaucoma, what is 21st century glaucoma care, use of technology, telemedicine, and artificial intelligence, and also give you a glimpse of the future. Now, there's no talk on eye without giving an understanding, a broad outline of what the eye is. I think this picture may be familiar to some of you. I'm going to go through to the next slide. Now, this may be a more relevant screen. Now, this is a cross-sectional picture of the eye. For an eye to see well, starting from the front of the eye, which is the cornea here, through the pupil, the lens, the vitreous, the retina, and the optic nerve. All these layers have to be working well for an eye to see well. Now, what are some common eye problems among the older people in Singapore, in the world for that matter? These are the 4 major eye diseases: cataract, glaucoma, age-related macular degeneration, as well as diabetic eye problems. My talk today is glaucoma, but I'll just give you a brief outline of what some of the other eye diseases are, so that you can then focus on what glaucoma is. Now, what is a cataract? Again, this is a picture of the eye. This is a lens. The lens is clear. With age, the lens becomes cloudy. And the lens becomes cloudy, it disperses light and make the vision blurry. Now, what do cataract patients see? They see a diffuse blurring of the image. The next condition is ARMD. This is a condition where it affects the macula or the center part of the retina. And what do patients with ARMD see? Instead of a more diffuse blurring of vision, it's a more centralized blurring of vision. And in some of these patients, there's distortion of the center of vision. How about diabetic retinopathy? Now, diabetic retinopathy can affect the back of the eye, the retina. It can cause bleeding and small bleeding spots in the eye. Now, what do diabetic patients see? They can see blurred vision, or if there's a bleed in the eye, they can see a sudden increase in floaters or sudden loss of vision. Now, back to the main topic of today. Glaucoma. Very often it's called the silent thief of sight. What is glaucoma? Now, the main definition is very long. Well, it's actually a group of eye disorders affecting the optic nerve with a characteristic visual field damage. Raised eye pressure is the major risk factor. Now, there's a whole long list of what glaucoma is. You have the primary glaucomas, secondary glaucomas. Glaucomas do not just affect the elderly, as you heard earlier today from Dr. Fazila. It can also affect babies and children. Now, you have seen what cataract can do. It can cause diffuse blurring of vision. ARMD can cause central blurring of vision. Diabetic can cause a sudden increase in floaters or a sudden loss of vision. Now, what do glaucoma cause? Now, in the early stages, the vision stays normal and there is no pain. What the patient experiences is very often the beginning of loss of peripheral vision. So when a person loses vision, they may not notice it in the early stages. See the center vision here, again, this picture here remains clear. And with time, it becomes narrower and narrower and narrower until a patient experiences a tunnel vision. Now, if you leave it alone and untreated, the patient will lose will experience complete darkness, a complete loss of vision. Now, this is the more chronic, what I've shared with you earlier is a more chronic form of glaucoma. Glaucoma can also present acutely, okay, with sudden rise in pressure inside the eye. In this kind of situation, instead of a slow loss of vision, as in a silent T for sight, the patient experiences sudden headache, eye pain, nausea, vomiting, seeing halos around lights, decreased vision, and the red eye. This happens more commonly in our population, our Chinese population, amongst the elderly, female. Now, how is glaucoma detected? I think we all know that a complete eye examination is important. This is especially so in the elderly, those with family members who have glaucoma, very, very important, those with past injury to the eye, and those with some of the risk factors. When a person goes for examination, they go through a series of tests, starting with the slit length examination, pressure check, optic nerve examination, as well as gonioscopy to look at the angle of the eye. The patient then will go through a test to test the visual field. It's a specialized machine that tests the peripheral vision. And there's also a whole host of new technology where we can image the nerve as well as the retina. This gives us a more objective view or objective measurement of what the structures inside the eye is. Now, what are the goals of therapy in glaucoma? The goal is really to maintain useful function and the patient's quality of life at a sustainable cost. What is the aim of treatment? The aim is to preserve, not reverse. In other words, whatever that's lost from glaucoma cannot be restored. How can it be treated? Again, there are three main methods of treatment. We can use a series of medications such as this, a whole host of different eye drops. We can use laser surgery as well as do incisional surgery. This is just a slide of laser surgery being done. It's usually done seated. In this slide here, the patient receives a laser treatment where a small hole is made in the peripheral iris. This is the treatment for angle closure glaucoma. In more severe or more advanced cases, we do glaucoma surgeries, incisional surgeries, where we create little channels inside the eye to allow pressure to flow and leave the eye. In even more advanced cases, we put small little tubes like this. If you look at this picture here, this is a tube, and this tube is inserted into the eye. It's very much like plumbing. It's actually really to drain fluid from inside the eye and lower the eye pressure. When you lower the eye pressure, you protect the eye from glaucoma. Now, how common is glaucoma? Well, Asia, being the largest continent, has an estimated 21.5 million blind people and another 67 odd million people with low vision. In 2010, 65 million individuals worldwide were estimated to be affected by glaucoma, with the majority in Asia. Now, I would like to draw your attention to these three populations here. Obviously, these are the three major populations that we have here in Singapore. And we have three major studies done in Singapore over the last 20 odd years, starting from the late 1990s, early 2000 with the Tanjong Pagar survey where we studied the Chinese population, into the mid 2000s where we studied the Malay population, and the early 2010 where we studied the Indian population. Now, in all these studies, we found that for the Chinese population, we have a 3.2% prevalence of those aged 40 years and above. For the Malay population, it's not far off, it's 3.4% of those aged 40 years and above. The prevalence of glaucoma among the Singapore Indians aged 40 and above is roughly half of the Chinese and Malay, of about 1.95 population percent. Now, I would just like to draw you on the Chinese population, just to keep the talk short. So as I shared earlier, 40 years above is 3.2%. But if you look at the population aged 70 years or more, it's as high as 10%. In other words, if we have about 100 odd participants here today and all of you reach past 70 years old, at least 10 of you would be having glaucoma. So glaucoma is the second leading cause of world blindness after cataracts. It is the leading cause of irreversible blindness, unlike cataract. So what is the burden of glaucoma? Well, glaucoma impacts a wide spectrum of activities. Glaucoma sufferers have significant difficulty with key daily activities like reading, walking, driving, and have a higher likelihood of motor vehicle incidents, falls, nursing home admissions, anxiety, and depression. Now, you look at this slide here. Now, what we take for granted when we walk into the supermarket may be quite easy. You know, we are rushing in, we want to get this and that product and taking from all the different parts of the shelf. For a patient with glaucoma who has lost part of his field or his or her field of vision, looking for a simple product off a supermarket shelf may just be quite challenging. So, what are the other burdens of glaucoma? Recent data have indicated that hypertension, hyperlipidemia or high cholesterol, stroke and diabetes are also more common in glaucoma sufferers, which in turn may affect quality of life as well. Furthermore, the financial burden of hospital visits, medications is also considerable. So what is 21st century glaucoma care? I mean, you've heard earlier all the tests that the patient has gone through. What I would like to essentially put it down to is actually personalized care. Improvement in diagnostic accuracy as well as prediction of future cause of glaucoma have greater impact in glaucoma care than newer forms of surgery. In other words, being able to predict the cause of the patient is more valuable than having the latest form of treatment. Why do I say that? You see, if I have two patients, if I can predict that one patient is going to progress or get worse faster than the other patient, right? I would then not have to use a big hammer for the better patient. I would just need to use a small hammer or small treatment for the patient that is less likely to progress. If I can predict that this patient is likely to progress faster in the future, I would want to throw everything that I have on this patient. You must understand that the more treatment that we provide, there's also the collateral damage with treatment. So that's why being able to predict and personalize the care for the patient is more important, is the most important in modern treatment for glaucoma. The other aspects of 21st century glaucoma care is empowering of patients. I think you heard today from many patients with the use of technology hastened by COVID-19 means that we must give more power back to our patients, give them the ability. So easier to use home monitoring devices such as the iCare home tonometer can be used. This is a picture taken from the Straits Times photo in March 2017 where the patient is able to use a tonometer. This is a device to measure pressure which he can use himself at home and then report back to the doctor without having needed to go to the clinic to see the doctor. Mobile apps, I think you heard today from Ms. Charity Y from SNEC, the capability that mobile apps can provide in reminding patients to apply eye drops in home testing. Telemedicine and AI, I think time for, even without COVID, without the fear that we have of meeting or encountering people, just taking time away from work or leisure to come for eye examinations is already a serious barrier to effective management. So what we can do, we can provide off-site test facilities, which could be set up in multiple locations in partnership with optical shops, pharmacies, or even other medical offices. With capturing of this data, we can then use tech to either Skype, Face, or Zoom time with the physician. And for the more complex issue, we arrange a face-to-face meeting. How about a glimpse of the future? Well, I've talked about the easy-to-use monitoring devices for visual field tests, pressure measurement, and optic nerve imaging. With the capture of more data, we can use AI to process data for mass screening. We can downsize the load that we have in a population down to a smaller number so that we can then process and treat more effectively. Now, how about on the medical front? Now, as I mentioned earlier, that glaucoma patients sometimes have to put many different medications. Now, and you have to remember to put it daily. If there is a sustained drug delivery device where it can be introduced to the patient, let's say, which will last about 3 or 4 months or even 6 months, it will do away with all the situations where there is non-compliance with medication. Well, we also hope for that's a magic pill or a poly pill that can, one pill that treats all kind of glaucoma. Well, we'll work for that. Lastly, now I would like to just add a caution about collateral damage or innovation. While we would like to embrace technology as something good, I must really caution that every time we embrace technology, there's always collateral damage. A good example is cataract surgery. Now, the modern cataract surgery is highly efficient and highly effective. But you must understand, throughout the last 20, 30 years, even the implant alone that we talked about, we heard that is a $4 implant, many different materials have been used to create or to manufacture the implant. And many patients have actually lost their sight from wrong use of material over the time. What we see today is accumulation of different years of innovation with some collateral damage to some of those patients who have suffered along the way. Well, actually, this is pretty much the end of my talk. I would like to share some slides. I take the last 1-2 minutes to share slides because RC Singapore is one of the major sponsors of this meeting. This project of 8 Rotary eye hospitals. This is has been 30 years, 32 years and ongoing. This is one of the oldest ongoing project of RC Singapore. It involves the active setting up or upgrading of 8 different hospitals across 4 districts in India. The 8 hospitals are Hooghly Eye Hospital, Susrut Eye Hospital, Cataract Eye Hospital, Bhubaneswar Eye Hospital, Purulia Eye Hospital, Lalpur Eye Hospital, Aurangabad Eye Hospital, and Buxa Eye Hospital. And over the years, RC Singapore has had a hand in 45 cataract surgeries per year. Approximately 14,000 of these are free, each surgery costs $38 per patient. Again, approximately 10,000 are subsidized. For free and subsidized patients, they provide meals and point-to-point transportation. And approximately 21,000 are private patients. That means they are paid for. This helps ensure the financial sustainability of the hospitals. And these hospitals see almost 2,000 outpatients every day. Well, I'm coming to the end of my talk. I'd like to take this opportunity to share with you this announcement. This is an announcement for 14th October, mark this date. This is the inauguration ceremony of the specialty clinic, the retina clinic for the Rotary Hooghly Eye Hospital. The primary partner for this project is RC Bugis Junction, President Roger Ng, as well as financing from PDG Chew Gim Box Rotary Endowment Fund. Well, this brings me to the end of my talk. I hope you enjoyed what I've shared. I know there's limited time. Feel free to contact me directly if you have any further questions. Thank you.
Dr. Ho, thank you for that. That was perfect timing, actually, and an excellent introduction to glaucoma for all of us. Thank you for being such an upbeat presenter right at the end of the day. It really helps. We've finished all the official speakers already. I'd like now to hand over to past District Governor Leslie Salehuddin, where we would like to present some awards. I will let PDG Leslie cover that. Over to you, Leslie. You're still on mute. Leslie, we cannot hear you. You're on mute.
Can you hear me now?
Yes, we can.
Sorry. Okay. Yeah, thank you so much, Surinder. Yeah, we've come to the part that we have the awards for the inaugural Rotary Sing Eye to Eye Frank Devlin Awards for blindness, support for blindness prevention. And we have actually done this on an earlier scale in terms of a pre-recording. So what we'll do now is that I would like all of us to perhaps watch the video of the recording that we have done earlier in terms of this award. So over to you, Raj and the technical team. Could we play the video, please? Thank you so much.
This is the first time the District Action Group would like to take the opportunity to recognize individuals who have supported the blindness prevention activities of Rotary in Malaysia. And hence, we decided to have this event today so that we can in person recognize the individuals and at the same time, hopefully it could be publicized of their work they have done to contribute to this cause of blindness prevention.
To see
stands for Seeing Eye to Eye. Now, Frank Devlin is somebody, the dynamic and very, very committed to blindness prevention. He lived his life to the full in promoting blindness prevention.
Dr. Kula has actually mentioned a fair bit about our past president, whom this award is named after, Frank Devlin. If I may just add, Frank was really a towering gentleman, all 6'5" of him. Whenever you walked in any Rotary conference, will not miss Frank Devlin. And he would always be happy to pass to us who are present that piece of spectacle cleanser, that very nice piece of cloth for you to clean your glasses. Yeah, but that is really the man. And his theme for his year was Create Awareness, Take Action. And those of you, the Rotarians who have been in Rotary for a while, will remember that his logo had the shape of an eye, right? A shape of an eye. So he's very much an eye man, as you said.
So we decided to embark on that and decided to work towards tormenting people in the dark. That's what we do, dialogue in the dark. To let patients, let family members, and also let the public, corporates, government agency, as they go through that short little journey of the dark, aside from telling people the importance of their eyesight, it is also about appreciation, gratitude, and of course empathy for those less fortunate than them.
I feel very honored. I believe that when I received this award, award is a sign for endorsement of our work in Ministry of Health as well, and to indicate that this collaboration will not stop here. Our journey is still very long way to go. There's a mountain to climb. We are still at the base of the mountain. We still need to climb furthermore. So I believe this is an award for me to work harder, for me and for our colleagues in Ministry of Health, and for all of us to work harder in the community to prevent blindness.
I'm very surprised at how much we actually contributed over the years, and it's been a great honor for Foundation to partner with fellow Rotarians on District 3300 and 3310. Your perseverance in the community public service has been astonishing, and it's been a great honor to be part of your journey.
That was the video of the presentation that we've done earlier to Mr. Stevens Chan of Dialogue in the Dark, as well as Dr. Muhammad Aziz Salovi, consultant ophthalmologist, who have been a great supporter of eye prevention projects with Rotary and in partnership with us. And of course, last but not least, the CIMB Foundation, represented by the manager, Mr. Eugene Chiang, who again has provided so much of funds for both our districts, for 3300 and 3310, for eye care projects in both cataract surgeries and eye screening. And with the 3 awardees, we're so delighted that you were able to join us earlier, and we salute the 3 recipients for the great support and recipients for the inaugural Rotary C. Frank Devlin Excellence Award for supporting blindness prevention. So thank you once again, and congratulations once again. Over to you, Surinder.
Thank you, PDG. I'm sure everyone here also shares the congratulatory notes to all 3 inaugural recipients. We now hand over to past district governor Siti Zubaida.
Thank you. Well, it really is a long afternoon, and I really take this opportunity to thank
all of you for staying on, and we exceeded that time. Sorry for it. But it was such a day where it is an enriching afternoon with a wealth of information from our most distinguished speakers. How important is it to keep sight of our vision, which we sometimes take for granted? Thank you, dear speakers, for your valuable time this afternoon. It was amazing the time that you shared with us. Not only were health issues and medical concerns that was highlighted, but how we as volunteers and service organizations like Rotary could explore and expand in carrying out our humanitarian service both at home and abroad. The many opportunity we have to work with other NGOs and like-minded organizations and individuals will certainly allow us to reach out to deserving children and families. Reaching ASEAN and beyond is not just a tagline, but is our fervent hope that together we could reach out to each other to give hope to sight. I take this opportunity to also recognize our major donors, major sponsors, the Rotary Club of Singapore from District 3310 and the Rotary Club of Kuala Lumpur Diraja for District 3300 for their generous contribution of Ringgit Malaysia 5,000 from each of the club. Your contribution goes towards furthering our cause through our 5 task force, early intervention program, teaching teachers in basic vision screening, low vision screening and free spectacles to underserved children, helping our seniors through our elderly eye care projects, awareness and screening for diabetic retinopathy and increasing disease among diabetic patients, and of course, awareness in industrial eye safety. Your contribution will certainly help the action group focus on these areas in reaching out to our community. Once again, thank you. And if any one of you who wish to join and contribute, please do, because it does help us in the long run. To you, our audience, our friends and fellow Rotarians, thank you for joining us in this virtual conference. You filling up the hall, or rather the screen coming from near and far, not only is an overwhelming day for us, but it inspires us to do more for the visually impaired. As an action group and as individuals or Rotarians who are passionate in this cause, it has been really an enriching afternoon. This event is organized and managed entirely by the members of the District Action Group on Blindness Prevention, supported by our district technical team. It is only possible with their commitment and being able to see eye to eye in everything that goes into organizing this event. We really and truly enjoy putting this event together and the opportunity to share. Thank you, DAGB members, and of course, under the leadership of DAGB Chairman Dato' S. Kulasekaren. So where are we going next year? Seeing Eye to Eye is an annual event, which is a joint project of District 3300 and 3310. And next year, the host district is District 3310. May I now invite Charter President James Gomez, Chairman of the Blindness Prevention Committee of 3310, to announce where we are heading for SEEC 2021. Over to you, James. He's unmuting.
Good conference today, and we hope to do the same next year when we meet in the city of Kota Kinabalu, the state of Sabah, East Malaysia. We hope to meet all of you at the beautiful location. Thank you.
Thank you, James. It now gives me great pleasure to hand over the symbolic Sayangi Mata pin to DGE Dolly Yip, our host for SEEC 2021 in Kota Kinabalu, Sabah. Dolly, I hope you're online. This is what we are going to do. I'm just going to hand over the Sayangi Mata pin to you, and I hope you receive this from your end.
And this is what virtual does it. Okay, you got it. Great. So Dolly, over to you next year with the team from 3310. Thank you so much. See everyone, guys, and God bless you. Over back to you, Surinder. Okay, now you can talk.
Okay. Thank you very much, Siti. With that, we've come to the end of our session today. To everyone who joined in, thank you. We hope you found this informative and educational. If you need any material or you would like to get in touch with any of the speakers, please just get in touch with your respective district action groups, and one of us will give you the contact or the resource that you need. With that, we call this to a close. Thank you, everyone. Bye.
Sabah, Malaysian Borneo, a land of green canopies and glorious sunsets. Sabah possesses one of the richest biodiversities on the planet. With 53% of its landmass covered by forests, Sabah holds the oldest rainforest in the world. The state government have vowed to expand Sabah's total protected area to 30% of her landmass in the near future. Here are Sabah's invaluable natural resources, sheltered in vast conservation areas. It is in these undisturbed forests where curiosities, such as the world's tallest tropical tree, can be found. The rivers are the lifeblood of Sabah's ecosystem. Crisscrossing the length of the state, they nourish all creatures from the inland jungles to the coastal wetlands. Here in the intertidal zone, the marine life that flourishes along Sabah's coasts is nurtured under the boughs of mangroves. In the branches above, Borneo's iconic proboscis monkey makes its home. As the mangroves give way to the open ocean, Sabah's underwater beauty is unveiled. Tranquil islands and world-renowned dive sites surround the state, encouraging the state to gazette a number of marine parks in an effort to preserve these marvels. Visitors to these spectacular sites are accommodated by high-quality resorts set in extraordinary vistas. But great accommodations are not limited to Sabah's islands. Far above sea level in the highlands and pastoral valleys, local residents have opened their homes and provided visitors with homestay opportunities, where they can experience traditional living alongside the many indigenous peoples of Sabah. Here too, in these mountains, stands Sabah's most prominent landmark, Mount Kinabalu. And situated within the acclaimed Kinabalu Park, a UNESCO World Heritage Site. Downhill, the slopes give way to waterfalls and rapids, prime locales for thrill seekers to indulge themselves in adventure sports activities. For those in search of more leisurely pursuits, Sabah offers breathtaking golf courses that span a myriad of biomes. From the upland valleys to the lowlands of the coast. The coastal towns and cities built along the rim of the state are where the majority of Sabah's people make their home, each hosting their own peculiarities and attractions. Within these towns and the surrounding countryside, Sabah's diverse and intriguing cultures, rich in food and dance, come alive. A glimpse may be witnessed in the yearly festivals and markets held across the state. From the Tamu Besar of Kota Belud to the smaller Sunday fairs of Gaya Street, convened near the modern comforts of Kota Kinabalu, the capital city of Sabah. Here in the gateway of Sabah, quality accommodations, shopping areas, and food outlets abound. It is a thriving, ever-developing city, as much a venue for pleasure as it is a great place to do business. The meetings, incentives, conventions, and exhibitions, MICE activities, have done well to improve the economic conditions of the local hotel, shopping, transportation, property, and services industries. Sabah, Malaysian Borneo. Savor the sights and sounds of a land blessed with natural wonders and cultural heritage. A destination that promises to leave a lasting impression. Nanti kau menyesal tiada guna. Nanti kau menyesal tiada guna.
Hello, everyone. Hello.
Hi.
Thank you for staying on.
Long day.
Very long day, but no choice. It's like we have all these part of this conference, an annual conference. You know, we have people going in and out. Good. And some stayed on full. I think that took us, we were full from 4 hours. Now full for next 4 hours of the thing. I think at least 50 people were full for 4 hours. That's really a big. Thank you, Surinder.
Solid.
Yes, very long session, but very good.
I'll try to keep awake now at certain time.
But sometimes, like you say, we take our eyesights for granted.
Yes.
Only hope the batch thing help.
Hi, Siti. Hi, PDG Loy.
Yeah.
Yes.
Hopefully we can go and meet physically to Sabah.
My badge.
Looking forward to travel.
Yes. Thank you. Never know Sabah is so beautiful.
Yeah.
Wow.
You're in Sabah next year.
Okay, bye. See you.
Bye.
Philip, thank you for being on, Philip.
Thank you for a great session. Bye.
Thank you. Bye.
Thank you.
Bye.
Okay, everybody. Bye-bye.
Fantastic.
Bye-bye.
Bye, Jason. Thanks for coming in. All the way from Thailand.
Congratulations, PDG, Siti, and your great team. Well done.
Yes, congratulations, Siti.
Yes, Stephanie.
It's really fantastic. With so many speakers,
Yeah.
Yes, fantastic.
It's so difficult to say no when all the topics were so relevant, and we don't want to be breaking up. We squeezed 2 days conference to 4 hours.
And you don't give any break at all.
We are drinking coffee all the time. You see? So you have the opportunity of sitting back and drinking a cup of coffee.
Closing, 10 seconds.
Yes. I've got all the technical team was just like waiting at the door, closing and opening, and I think it was fun. Thanks, guys. Bernard, Bohu and all.
Yeah, it's great. Really great.
Okay, see you guys. Thank you.
All right, bye.
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 All right, ending. Bye bye. See you next year.
See you.